Dr. Saurabh,
So,
I think start with the session.
Yes. Start the session. Lecturing is started. Right. Thank you, sir. Myself, Dr. Saurabh from Academy of Exercise Health and Therapy. I'd like to welcome you all on the second International Web Physio Summit on this Peads Colloquium. We have been doing this 4 colloquium already have been completed till now. This is the as a chairperson, Reena Kumari. She just had got the vaccination, so she is not well. She will be joining us. Nandita. She is an assistant professor, ma'am. And we have our two esteemed speakers as well, Dr. Sapna Diman and Dr. Ushma Goradia. Welcome to you all. Thank you for sparing time with us. This Web Physio Summit is being organized by Academy of Exercise Health and Therapy in collaboration with academic partner Assam Downtown University and European Register of Therapists. Also, our academic partner is OsteoPro. Welcome to you all, and with the permission of Dr. Nandita ma'am, please allow us to start the session. Ma'am, please say a few words.
Yes, sir. It's an honor to be a part of the seminar. And yes, sir, please carry on, sir. Thank you for inviting me.
Thank you so much, ma'am. Thanks a lot. So, Dr. Sapna Diman, she's MPD in pediatrics and a PhD scholar. She's an assistant professor in School of Physiotherapy, Dairy Paramedical, Pharmaceutical Sciences and Research University. Welcome, ma'am, and please continue your presentation. We are waiting eagerly to hear you.
Thank you, sir, for the kind introduction. I hope I am audible.
Yes, ma'am, you are audible.
Thank you. So, firstly, I would thank the Dr. Chirag and the entire organizing team members of this second International Web Physio Summit for giving me this platform to express my views on this particular topic, that is facilitation of trunk in children with spastic cerebral palsy. I must congratulate the entire team members for organizing this event in such a systematic manner, which is not only, you can say, beneficial for the students, professionals, but also for the resource persons or the speakers, which is actually sharing their knowledge about the different aspects of physiotherapy. So with this, I start with the topic. So I hope my slides are visible to everyone.
Yes, ma'am, it's visible.
Okay, thank you, sir. Thank you. So as we all know, among the pediatric population, cerebral palsy nowadays is one of the leading cause of the chronic disability. And it usually defined as a permanent disorder of movement and posture, which is actually limiting the participation of the child in their day-to-day activities. And which is due to the result in the, you can say, insult to the developing fetus or the immature brain. If we talk about the prevalence, that is around 2.95 per 1,000 children. And the types of CP or the CP is basically broad categorized into the three major types, that is spastic, dyskinetic, and ataxic. Among all three, the spastic is most common, and it is usually characterized by hyperreflexia, that is the exaggerated reflexes, and hypokinetic. That means when the child is performing any kind of a voluntary action, so there is hyper stiffness. And that hyperstiffness is actually causing or limiting the movement, which has resulted into hyperkinesia behavior of the movement. And if we talk about pathophysiological lesion, that usually lies in the white matter and around the corticospinal tract. In this kinetic type of a CP, this basically it is divided into three types, that is dystonia, ethitosis, and chorea. And ethitosis and chorea is actually like you can say how we can differentiate this thing. So in ethitosis, there is regular and slow continuous rhythm movements. The involuntary movements are continuous and that are slow. But when we are talking about chorea, it is random movements. And that random movements are usually present in the fragment of movement activities. And all the three are characterized by hypotonicity. In dystonia, there is hypotonicity at rest, but when child is allowed to do any kind of a movement or there is transition in the posture, it results in hypertonicity. And its lesion is usually lie in the basal ganglia. Ataxic CP is usually because of the damage to the cerebellum, and it is characterized by intentional tremors. And depending upon the distribution to the you can say to the all different areas of the body, it is also termed as quadriplegia, diplegia, and hemiplegia. And in that also, depending upon their functional abilities or their severity level, so the cerebral palsy is classified or categorized according to the functional level by the gross motor function classification system, that is GMFMCS. And GMFMCS is usually have 5 levels of classification. And this 5 levels is usually define the child ability, their functional ability basically. So level 1 describes that the child will be able to walk, or child is able to walk without any restriction, and when there is few limitation when child is going for a advanced gross motor skills. So advanced gross motor skills means if the child is going to hop for on a single leg, or climb a stair, or ascending doing the ascending and descending of a stair by holding some kind of a weight. When we are talking about level 2, in this again, the for indoor mobility, the child is having no restriction. But when child is going for outdoor mobility or for the community, the child may need some support. For the level 3 means assistive device. The child needs assistive device for the mobility. For indoor mobility, maybe the child need walk, you can say the cane or the elbow crutch or the tripod cane. And for the outdoor mobility, the child is depend upon the manual wheelchair. For level 4, for the you can say the level of dependency is increasing as compared to the level 3, so the assistive device need is also increased. In this, for indoor mobility, the child may need rollator or a walker, and for the outdoor mobility, child is depend upon the power wheelchair. And level 5 is completely dependent for the indoor as well as for the outdoor activities. As we all know, that the children with cerebral palsy is usually having problem in their immature brain, or you can say during their developmental phase, they have an insult to the developmental brain. So because of which there is delayed in their development, and this delayed development leads to impairment into the various system. That system can be sensory, musculoskeletal, or neurological. And because of which they have a problem in the awareness of their body with respect to their environment. So when they have this problem, like they are not aware about their body system or their posture with respect to environment, they have decreased variability of the movement, exploration of the environment is low. And all these things leads to impairment in their perception. The perceptual aspect is not developed properly. So ultimately, child may rely on either on a single, you can say sensory system, though their development is depend upon the multisensory system. But the child may rely only on the one system, that may be the vision, maybe the hearing, or maybe the any other system. So ultimately, all these neuromuscular impairment in children with cerebral palsy resulted into abnormal posture, loss of selective motor control. There is there is poor trunk control and ultimately impaired balance, which contribute to the impaired postural control, and this impaired postural control limiting their participation in the society, because the postural control mechanism is the important factor when we are talking about their participation in day-to-day activities. So they during their development, this postural control or the posture is actually providing a base for their head and trunk movement, on which the child is able to perform the different activities of upper limb or the lower limb, so that they'll be independent in doing their reaching activities either in sitting or a standing, or ultimately to perform the skillful movement, that is like walking, running, or any other activity. So now the question comes that why this trunk is so important. So trunk is the play very, very important role when we are talking about postural control mechanism. Trunk is the factor, or trunk is the base on which the child is able to perform their different activities by using their upper limb or the lower limb. They are able to perform any kind of a reaching, any kind of, you can say, upper limb extremity when they are in a sitting position or a standing position. So this trunk control in children with cerebral palsy, what happened? They have a low tone in the trunk muscle when they are compared with the extremity muscle tone, or they have a weak muscle around the trunk, due to which they have a loss, or you can say the delay in their postural reflexes, and that ultimately resulted into the loss of trunk stability. So whenever there is no trunk stability, so the activities in sitting, standing, playing and sitting, or even during the manual, you can say during their mobility in the wheelchair is affected. So this trunk is formed by the, you can say it is basically the core, and that core is formed by the 4 different valves. The upper valve is formed by diaphragm, the interior valve is formed by the abdominal muscles, the posterior valve is formed by the back extensors or the trunk extensors, and the lower valve is formed by the pelvic floor muscles. So this core is providing the base on which a different anti-gravity flexion and extension movement can be performed with very ease. And this core is actually providing them a base for a different visual skills, for different perceptual sense of various fine motor as well as for the gross motor skills. And as I told you, the diaphragm plays a very, very important role, because this diaphragm is actually giving them a child a balance between their calmness, or you can say the arousal or the anxiety. So when we are talking about the strategies or the treatment, like what strategy or what treatment we have to use to facilitate the trunk, that basically depends upon 2 principles, that is motor control and motor learning. So when we are treating, or when we're going to treat a child with cerebral palsy, we need to understand their motor control aspect and their motor learning aspect. So what is this motor control? This is nothing but this is just the ability, or you can say ability or the direction to how to regulate the movement, and how this mechanism is important for the movement or any kind of a activity. This mechanism involves 2 type of a mechanism, you can say. One is the feedback mechanism, another is the feed forward. The feedback mechanism is also known as closed loop type mechanism, and this feedback mechanism is actually depends upon the sensory information present in the environment. So whenever the child is going to perform any kind of a activity, it depends upon, the child will depend upon the different, you can say, the different environmental sensations. And this type of mechanism is used basically to acquire initial skills. We can say जब बच्चा initial first 1 year में होता है, he is developing. So during his developing age, that is around 1 year, the child is depend upon this mechanism. This mechanism also depends, or you can say improvise the eye-hand coordination. Then coming to the next, that is the feed forward or the open loop mechanism. And under this, sensory information is important, but output of the activity or the actually the execution of any kind of a activity, motor activity, is not depend upon the sensory. It depends upon their, like, the skill, whatever they are learned or a practice during that first year or during the previous mechanism. So the examples are like walking or a running or eating food while sitting. All these are the skillful activities. This is basically the last stage, or you can say this is how the child will learn. That is motor learning. Now, as I told you, during the first year of the life, the child is usually depend upon the first mechanism, that is the closed loop type mechanism. And with practice and the skill, child will learn with different environmental cues. The child will learn how to modify their activity. And this is how they will rely on the feed forward mechanism or the open loop. So how this motor control develop? This development is actually involved two main things. First is the self-control of the movement, and second is how to change, how to, you can say, cope up with the changing situation or the changing demand of the environment. So the first problem which the child face is to maintain the body or to stabilize him or herself against the gravity. Then the second issue is the head control, because initially the head size is bigger than the body size. So that is the reason the first development starts with the head control, then girdle control, then coming to the sitting position, or you can say the trunk stability, then pelvic stability, and then standing. So this is how our developmental milestone develop. And later on, the child learns the skill. So then after that, once the sitting or the standing is achieved, then activities in these positions are very, very comfortable or easily like performed by the child. Sensations are also play important role when the development of the movement is there. So as you know, initially if we touch the corner of the mouth of a small child, he usually turn to that side. That is called reflexive movement. If we scratch the sole of the foot of a child, the child immediately withdraw the foot. That is also example of, you can say, reflexive movement. So initial movement pattern is also depend upon the sensation or also depend upon this reflexive activity. So this motor control is actually divided into the 4 stages, and these 4 stages involve mobility, stability, control mobility, and ultimately the skill. And these 4 stages are important when we are talking about development or when we are talking about intervention or any kind of a therapy. So how these stages are defined? Under the mobility, mobility is like any kind of a movement which is purposeless. Okay, so initial first 3 months, you can say initially when child is doing free kicking movements or free hand movement just to explore the environment. This is called mobility. Then stage 2 coming to the stability. Stability means maintaining the movement, maintaining any of the position against gravity. For example, forearm weight bearing or prone on hand. These are the different anti-gravity positions which the child start to maintain. And then comes the controlled mobility, which involves weight shifting. So this weight shifting concept is very, very important when we are talking about the development of the child. I hope I am audible.
Yes, ma'am, you are audible. Sorry to interrupt you. I
Yes.
think our chairperson, Dr. Reena Kumari, has also joined us, so we would like to welcome her. Welcome, ma'am. Thanks for sparing time with us.
Thank you so much, sir. Thanks a lot.
It's a lot. Please do join.
Shall I start?
Join us in the session. Thank you so much for joining us. Thanks, ma'am. Please continue your session, ma'am.
Okay, sir. Welcome you, ma'am.
Thank you, Dr. Sapna. Thank you so much.
So shall I start, ma'am?
Sure. Please
Okay.
continue.
Okay. So under this control mobility, the concept comes weight shifting, because once the child achieves the stability, that means maintaining the position, anti-gravity position. Now child is trying to do some of the weight shifting in that particular position. For example, in prone on elbow or in forearm weight bearing, on one forearm, the child may maintain the weight, and with the other arm, the child is trying to reach for a toy or play with the toy. So this is how the weight shifting concept come. And this weight shifting is actually the problem in the children with cerebral palsy. They learn, they know how to do movement. Even their mobility is also restricted because of their spasticity. And even they are able to maintain to some amount of time that anti-gravity position. But when it comes to weight shifting, that is transition between the different movement, that is sitting, supine to sitting, sitting to standing, that is the problem. Then coming to the stage 4, that is the skillful activity. And for the skill always come with practice and experience. So at the end, when child learn this mobility, stability, weight shifting concept, then the child is mastered into that particular activity, and the child is able to perform that activity without any support. So this is how we can divide the stages. And when we are planning any kind of activity, we need to focus on these 4 things. So this motor control system is actually depends upon the various external factors and the internal factors. The external factors include that the various base of support, the environmental adaptation, the various sensory organizations from the environment or the various sensory inputs from the environment, and ultimately their different systems, that is musculoskeletal, sensory system, the coordination among those systems. Then comes this motor learning, which is actually the skill. So motor learning is defined as the process. It is actually the process, or you can say the execution of the activity which comes after practice or the experience. So when we are training a child or when we are giving any kind of a therapy, our focus is we start with the motor control concept and ultimately we are ended up with the motor learning. So the motor learning is divided into the 3 phases. The first is the cognitive phase, second is associative phase, and the third is autonomous phase. So for the first, that is the cognition. So when the task is unknown to the child, or you can say any new activity is performed by the child, it depends upon their cognition level. How the child understanding that particular thing, or you can say this phase depends upon that closed loop mechanism, the feedback mechanism. Then coming to associative phase, in this different association, like for motor performance, the association between the success and failure is very, very important, along with the sensation. That is, the child will learn with their trial and error method. So here I just want to quote one example. You know, the getting up from the sitting position is very, very easy for the child. They always take a pull in themselves and they getting up straight. But when they are learning how to get back to that position or sitting on a floor is difficult. So what happened when they start getting up from the sitting, or they start from sitting to standing, it is easy. But standing to sitting is difficult. So they're always going, you can say, banging themselves, वो नीचे बिल्कुल गिर जाते हैं. So once they are doing that on a repetition mode, then they learn that control manner. And then how they in a control manner, or in a, you can say, because when we are doing activity towards gravity, we need some eccentric control, and that eccentric control develops later with the, you can say, with more practice. Then at the end comes autonomous phase, that is again a skillful, or the child is mastered in that particular task. So you can say no attention is required to perform that activity. So with these principles, now we are discussing few of the strategies with which we can improvise the trunk control in children with the spastic cerebral palsy. So initially we need to give them sensory preparation, and this sensory preparation is actually important for the arousal of the child, for having their active participation in the session. So for that, you can take a therapy ball, or make the child sit on that therapy ball and give them a bounces, or you can say the simple up and down bounces actually give them a vestibular stimulus. And this vestibular stimulus or proprioceptive stimulus is giving them an awareness of their body. Then with the help of the therapy ball, we can give them a deep pressure. And this deep pressure is actually very calming or relaxing, which is allowing them to actively participate in their session. We can use different swings to give them different senses. We can use bolster swing, or you can say this lycra swing, because in the lycra swing the child is having a more of a deep pressure or a proprioceptive sense, because in children with cerebral palsy they are not having free movement, they're not exploring their environment, so their this vestibular system, this proprioceptive system is underdeveloped. Then after this preparation, you need to go for a correction of the alignment. Because when we talk about the activation of the muscle or facilitation of the trunk or any muscle, we need to have a correct alignment. For the correction, we know children with cerebral palsy usually sit with the slouch posture. Their neck is flexed, their thoracic spine is into flexion. So active extension is limited or even not present there. So as a therapist, we can passively elongate their upper trunk or pectoralis major muscle, you can say. So you can say in this picture, the therapist or the child is sitting on a bolster, and actively the therapist is elongating the pectorals. Or how actively the child can do that, we can place a one small ball between the therapist and the child, and then child is asked to press that ball. So with scapular retraction, there is active lengthening of the pectorals. And this correction of alignment is actually giving them a proper base. And if the proper base of support is there, so they can improve their range, their mobility around the joint can be improved. They can use their trunk activity, and their movements in the limb is becomes easy. So you can see in this picture also, the therapist by placing his hands on the scapula is actually providing a better alignment to the upper trunk so that head and neck can be facilitated or actively controlled, so that their vision can be used for that particular activity. We can use posteriorly inclined wedge, which is actively give them an active extension at the lumbar spine. Then for the smaller children, we can use bolsters, or for the, you can say a little younger children, we can, or elder children, we can use a ball. So on ball, therapist can take a child on a ball, and then on the back side, the therapist maintain the alignment, and from the front side, mother or any other therapist can just make the engage the child in any kind of a activity, so that actively child try to reach for that particular toy, and then try to hold that toy for some time, so that the reaching and holding is important. Because once the child is going for a reaching movement, there is a weight shifting, and then after reaching, when child is trying to hold that position or hold that toy for a, you can say, particular time, then again it is maintaining that position or holding or activating the muscles or maintaining that contraction actually. Then we need to focus on facilitation of the thoracic extension, because usually what happens, their thoracic spine is always in a flexion mode, so the active extension is compromised. So again, the child can be taken on the therapy ball. The therapist is maintaining the hip and the lower trunk extension and lower extremity extension, and mother is engaging the child, and child is trying to playing with the toys, or you can say any other activity. And this bilateral extension is actually giving them a better, you can say, thoracic extension. And this thoracic extension not only improvise their posture, but also give their space for breathing also. Okay, and in this also you can see the child is sitting on a bolster, therapist is behind, 90-90 position is maintained, 90-90 is hip is 90, knee is 90, foot is in the 90 position, and therapist is taking the arms overhead, and this overhead position of the arm is actually helping to minimize the internal rotation at the shoulder, and also the upper trunk flexion can be controlled. So we can, then the child is allowed to see, rotate, so that by correcting the alignment, we are activating the different muscles. Then coming to the trunk rotation in sitting position. So again, on the therapy ball, therapist with the hand, like the therapist hand is trying to give them a proper base by extending their lower trunk, pushing their pelvis to the ball, giving them stimulus also, because ball is giving them vestibular stimulus, giving them sense of proprioception. And when they are having this all things together, sensation is there, base is there, then child is allowed to do some activities with upper extremity, because when child is doing upper extremity activity, the trunk is automatically get activated. In this position also, the child is sitting on a bolster, and on the side the ball is kept. Then side rotation is facilitated. Therapist is actually facilitating with some of the manual touch or manual vibrations, and child is allowed to push the ball or pull the theraband, so that along with that some strengthening exercises can be performed. This is also to show you how we can do the trunk rotation activities on sitting on a different, you can say, table height. In this also we are maintaining 90-90 position. So now comes the dissociation activity. In children with cerebral palsy, dissociation of extremity is the big issue. Lower extremity dissociation is the problem. That is why they're having a scissoring gait. So as a therapist, we need to dissociate their lower extremity. So this is a kind of an activity. In this, you can see the therapist passively dissociates the child lower extremity, and child actively hold this position. So when child is allowed to actively hold this position, actually child is maintaining the extension of the trunk. And along with the extension of the trunk, the lower extremities get dissociated. So this is the, you can say, preparation for the standing or the walking. So once the proper sitting is maintained, now the floor sitting can be achieved, and the child is independently sitting in a ring sitting position. And therapist is just by giving few, you can say, maintaining the alignment with few touches, and then again the child is engaged in the activity. That is more important. So active rotation, you can see with proper alignment, rotation is there. This is how we are facilitating the different components when we are talking about activity. So this weight shifting concept, this dissociation, this trunk rotation is important aspect when we are talking about transitions, because children with cerebral palsy is always having a problem in transitions, moving from one position to another, because this needs dissociation, this need a rotation component, this need a weight shifting component. So this is again a one way by which we can improvise their weight shifting concept. When child is ready to walk with the help of a walker or a rollator, as a therapist we need to connect the upper trunk with the lower trunk, or with our support we are actually trying to maintain the hip in extension, so that the dissociation or hip extension, walking with hip and hip extension and trunk extension should be maintained. Then coming to the standing activity, first the child is allowed to stand with the help of some support, and that support can be taken from the different balls or any kind of a support from the standing, and then try to maintain that standing position by holding something. And then in this standing position, different activities can be given. This activities can be in the form of rotation. In this, the therapist is maintaining the position, and now you can see in this also the child is engaged in a playing, and the therapist is maintaining that position. In this, ball is a therapy ball is taken in front of the child. Therapist is maintaining the alignment of the knee. With one hand, child is taking a support with the ball, and with other hand, the child is actually, you can say, child is actually playing or moving something. So it is giving them a weight shifting in standing, giving them rotation component also in one activity only. This is how we can combine the activity with the sensory. So we are taking the child on a different, like if you're taking child on a ball and giving them bounces, so you are actually combining a different sensory stimulus along with the activities. This is also helpful to complete their skillful activities. We can take them on a different kind of a swing. So this is a gladiator swing, and this is a bolster swing, and child is allowed to perform the activity. So this is our small setup in our DIPSA University, where we are exclusively treating these children with the different abilities actually. So at the end, I must say we have different ways, we have different exercises, we have so many exercises with which we can treat these children. So whatever way, whatever exercise you are choosing, just focus on the two things. The first is participation and second is motivation. So whatever activity you are planning, try to participate the child actively as much as possible in 40-minute session or in 45-minute session. If child is engaged actively for 10 minutes, that is more important rather than passively performing the exercise. And do motivate the child on each task so that their motivation level, their arousal level get activated always. At the end, I just want to tell one thing: don't just treat them, play with them. So whatever activity you're planning or whatever exercise you are planning, plan that exercise in a playful manner so that the child can participate fully. Thank you.
Thank you so much, Dr. Sapna. It was a really awesome session, and we have to wait for 10 to 15 seconds just participants want to ask any question.
Sure.
Just we can wait for 10 to 15 seconds. And I'd like to ask our chairperson, co-chairperson, if they have any doubts or any questions regarding this topic, they can also ask, and they can also ask the question from her.
Dr. Reena, Dr. Nandita.
Yes.
You can
Well,
also ask.
Yes. Yes, sir.
Ma'am, if you want to ask any question from Dr. Sapna or Dr. Ushma, you can ask.
No, Dr. Sapna has very well explained all the things.
Thank you, ma'am.
Well, I have no questions with Dr. Sapna, but I must say in future, if we'll have any problem in treating spastic CP children, I'll definitely contact you. And you
Sure,
have
ma'am.
beautifully merged all the approaches, including the concept of motor control and motor learning, and how latently you have merged the roots approach and NDT. I can see in your slides, and it is very difficult to present CP in such a small time. Thanks a lot. Thank you.
Thank you, ma'am. Thank you.
Dr. Ushma, you can also ask if you want. Ma'am, please unmute yourself.
Yeah, sure. No, Dr. Sapna has done a wonderful presentation, and she has covered the most aspects of her topic as much as possible in this short time, I have to say. And in the process, she has made my work easier because my topic comes next, which is sort of a flow from her topic or a part of her topic. But she has made my work easier. She has mentioned a lot of terms here, such as, and covered, not only mentioned, but covered sensory impairments, motor control, how motor control depends on sensory organization, as one component. She's also covered the core muscles, which, again, are related to the vestibular system. She's covered weight bearing, weight shifting, that physiotherapists like us, we relate to weight bearing, weight shifting. Those are the terms that we use all the time when we treat a child, whether you treat from the NDT approach or any other approach. But then I have to say that they also come into the sensory integration approach. So, those are my favorite words. And of course, lastly, she ended up very well with this participation, motivation, play. Therapy has to be in the play form. I'm a great proponent of therapy being in the play form, not in the exercise form. In my clinic, I even say, don't call it exercise. Don't call it activity. Let's say, let's play this game, of reaching or getting this or getting that. That's a game. Don't use the word exercise or activity. That's how I do it in my clinic, to make it fun for the children and the parents. And participation is obviously, we know, a part of ICF. So that also you brought it in, no matter which patient we treat, orthopedic, pediatric, whatever kind of patient we treat, we have to be very watchful about the ICF components, whether we are addressing them or not. We should be addressing them. So very beautifully done, covered everything. Thank you. And thank you for making my job easier.
Thank you, ma'am, for your appreciation. And now I'm working on a sensory component only.
Okay. Yeah, I saw that in your videos, the video, whatever
Yes,
the last pictures.
Yes,
That's the way therapy should be. And therapy, each one, we have our favorite approaches, one or two or even more. But as a therapist, I feel none of us should be biased towards only NDT or only SI or only X or only Y. We have to think about the whole child, and we have to think how to pull out, these are just tools in our toolbox of therapy. So which tool to use when and how are the key components, to treat.
And I think it's entirely depend upon the child.
Exactly.
Child's ability.
The child and that same child will also differ at various moments, from week to week or month to month.
Yes.
Great. Thank you.
Thank you so much, ma'am. I think you both will make us learn a lot regarding the developmental disorders, and you'll at the end, I think we'll be able to get an integrated approach for developmental disorders of the children.
Exactly. Yes.
Thank you so much, Dr. Sapna. I think there are no more questions. Thank you so much for being there, for such a great gesture of your being available for our web submit, this colloquium. Thank you so much. And I'd like to invite Dr. Ushma to present her next lecture. And I'd like to ask Dr. Nandita and Dr. Rita to give us permission to start next lecture, please.
Sir, there is no need to take permission from us. So please carry on.
Thank you so much. Thanks a lot.
Okay. Please, thank you.
Please continue.
Thank you. Okay. Okay. So first of all, thank you, Dr. Chirag Verma and the entire organizing team to invite me to speak here. It's an honor, and it's a real honor to speak here and share what I know. So I think I have to share the screen. Yes. Okay. Okay. So mine, yes, I'm a physical therapist or a physiotherapist, but I've always been interested in sensory integration since more than 30 years now. I have worked in the United States for 17 years with wonderful OTs, and during my latter part in the US, I have also been in charge of training new or novice OTs. So, I've learned from everybody, whether I was being mentored or I became a mentor. I became a mentor to others. So, I would like to share all that. And I'm not NDT certified, but I'm extensively NDT trained, and I am sensory certified. I'm deeply interested in integrating both approaches. I also add motor learning heavily to my work. So I love to integrate all the three: NDT, sensory integration, and motor learning, and get better outcomes for my children. So now here, why did I suggest this topic is, this is a topic close to my heart. I practice it in my clinic day in and day out with every child. Every child teaches me something or the other in every session. And why bring sensory? So generally throughout the world, we see, even in the Western countries, there is a compartmentalization that, physical therapists work on gross motor, occupational therapists work on fine motor. Physical therapists generally do NDT, generally speaking, not all. And occupational therapists are responsible for sensory integration. But again, this is not true. When we look at a child as a whole, or any neuro patient as a whole, including stroke or Parkinson's, or adult neuro patients, we need to look at the person as a whole. Only then we can address the ICF components, because a person doesn't function as compartments, like here is motor, here is sensory. When we participate in function, or when we are functional, whether we are typical or whether we are going through neurological event or developmental delays, everything comes together. So sometimes I kind of feel when I'm doing activities or games in my therapy, I really don't know where does sensory start and motor ends, or where motor starts and sensory ends. It's a chicken and the egg. This is what I have always felt, and therefore we all need to be aware of both. So as physio, okay, so now I have many references. This is not an all-inclusive list, but I think every physiotherapist and every PT student should have the two of my favorite books are, one is Motor Control by Shumway, Cook and Wallacott, and the other one is Combining NDT and SI Principles by Blanche, Botticelli and Holloway. These two books every student should have. Even therapists who have not read, pediatric therapists who have not read these or gone through these should have these books. If you don't plan to get certified, that's not really necessary, but you can read these books and get a lot of information from here. And as always, clinical experiences have always taught me much more than anything else in the world, because we are dealing with a living, breathing, working organism, that is a human being, the child, in front of us, and that child changes from time to time. So we need to have our ears and eyes and mind very watchful all the time. Okay, so coming back to rehab now, starting with rehab, PT, OT or speech, the bottom line purpose of rehab or any therapy is to improve function, improve a simple function like coming to sitting independently, or coming to standing, or learning how to walk, or even complex functions which can be infinite in the world. Walking to school, carrying a backpack and walking to school. So there are so many complex functions either. Also, the main primary we know is to lead to, our therapy should lead to as much as independence as possible. That would lead to better participation in the home, school and community. And therefore, the individual or the child will have a better quality of life. That's our final target, to have a better quality of life. And reduce the caregiver burden. In case of children, it is the mother or the parents who really, carry, give a lot of assistance to the child, which we need to lessen or we need to decrease. And in case of an adult neuro patient, it is the family members, the spouse or the adult children who really have to do a lot for the patient. So our job is to lessen that burden and, the relief that they feel. So basically, we need to get better and faster outcomes of therapy. And therefore, we need to use as many tools as possible that are workable for this particular child at this particular moment. We have to have holistic intervention because we have to look at the child as a whole. And we also need to recognize some sensory flags or sensory symptoms, I would say, even as physiotherapists, even if you're not certified or you don't have in-depth knowledge of sensory integration. I think each PT student and physiotherapist, particularly working in pediatrics and neuro, should have some knowledge, some awareness of the sensory issues, or sensory symptoms as we call, so that we can make a referral to OT, and get better outcomes for the patient. So that's the whole reason why we need to know about the sensory systems. Now, sensory and motor. So Dr. Sapna has done a wonderful job of, covering the whole motor and how, the motor system is dependent on sensory organization. But I just want to summarize that sensory and motor are inseparable. Both the systems work in tandem with each other. They are interconnected, they are interrelated. There's a constant feedback between the two. And even Berta Bobath, whom we all revere and respect for, she's the founder of the neurodevelopmental treatment, that approach. Berta Bobath also many years ago, she postulated that a child does not learn a specific movement, but the child learns the sensation of movement, which means that the child doesn't learn, okay, take your hand up or move your leg forward. No, the child learns, the child feels a sensation as to how does it feel if you reach for a toy. How does your arm feel when you reach for the toy, or how does your trunk feel when you reach for the toy? So it's that feeling of that sensation, while you're doing any activity or game. So she was one of the earlier therapists to postulate this, and I think we have to remember this as physiotherapists. Again, sensations affect. So the sensory systems affect motor responses, they affect our behavioral responses, they affect our cognitive responses. So for example, now we have sensations coming from our own body, within our own body, and we have sensations coming from the environment around us at this time. So sensations, all these sensations, how do they affect my motor response? So for example, I'm sitting on this chair or the stool, and the stool is not very comfortable. So I keep on moving. If it gets very uncomfortable, I may just stand up. So that becomes my motor response, one example. Behavioral response. How do sensations affect our behavior?
Hello.
So if the, yeah, am I audible? I'm sorry. Am I audible?
Yes,
Hello?
yes, ma'am.
ma'am.
You are audible.
Oh, can I go ahead? Yeah.
Yes.
So behavioral response. So how do sensations affect my behavioral response? So for example, I'm sitting in this room, and if the temperature of this room is not to my liking, it is too hot or it is too cold, or maybe there's a lot of background in the next room, people are having fun and making a lot of noise, or there's a lot of noise on the street that I can hear. So I will tolerate all that for a while, but after a while, I'm going to become irritable and cranky, or I'm going to go out and shout at them or tell them to stop, If the classic example I give to everybody is, women, we like to dress up when we go for weddings. You dress up heavily, wear heavy saris, jewelry, spend a whole day at a wedding, or spend even 2 hours at a wedding, or if there's a function in your home and wearing all those heavy jewelry and saris, you're asked to cook for 2 hours in a hot kitchen. Yes, you will do it for half an hour, 1 hour, maybe. After that, you're going to start getting irritable, okay, and start, becoming cranky. So that's called a behavioral response. That's an example. And then cognitive response, same thing, that responding cognitively to somebody, answering somebody's questions when we are under the sensory overload, or when the sensory environment is not very optimal for us at that moment, at that location, we can't think cognitively very well. So therefore, sensations affect our motor responses, behavioral responses, and cognitive responses. So again, our feelings of becoming fatigued, being thirsty, being hungry, to a point we will tolerate, but after that certain point, we will not respond very well. So think about our children who come for therapy. If they have not slept the last night very well, if they're thirsty, some mothers in a rush to come to therapy, just give them a glass of milk and bring them, they're in empty stomach, even at 11 o'clock in the morning. And then the child is cranky or not doing what he or she is supposed to do. So there, starts my questioning. What did the child eat this morning, or what happened, or how did he sleep? That, that is an interoception part, which I'll talk again. But sensory always affects all our responses. So when somebody is not responding to you the right way, think about what's going on, in their sensory systems, in their performance, particularly when it comes to our patients. So sensory integration, what is sensory integration? Dr. Jean Ayers, she was the first one to think about sensory integration. And she was a brilliant occupational therapist. She also had a psychology background. And in her definition, she said that sensory integration is a neurological process. That means it occurs at the higher levels, for cortical and subcortical systems. And so these processes, basically, they put together or they organize sensations from our own body that come from within us, and sensations coming from the environment. Now, again, not that everything is put together at the same time and, put it out for functioning. No. At that particular moment, at that particular location, we only use the sensations that are needed meaningfully. We filter out the extraneous information. So for my earlier example, when I gave that, if right now you're listening to my lecture, you're looking at my screen, you're listening to my voice, and you may be filtering out the voice that goes on into your home in the next room. You will filter out, because that's not necessary for you right now. Right now, you're only focusing on looking at my screen and listening to what I have to say. You're filtering out the rest of the information. However, that same auditory information becomes very important when you're crossing a busy and a noisy street. Imagine yourself crossing a street holding on to a child. That time, the honking of cars around you, you're paying more attention to that, and you're pulling your child across the street to accomplish the task of crossing the street without having an accident. Okay. So sensory integration, when we were all novice therapists, we would give an example when we would talk to parents is, sensory integration is basically, imagine you're driving a car in a busy street in heavy traffic. And what is your goal? Is to get your car from point A to point B or reach home without hitting the car in front of you. And more so, imagine if you have two kids talking and screaming in your back seat. What happens? You are going to filter out. I'm not saying you're going to suppress. That's, certain words or certain terms can be used wrongly or rightly. It's not even ignore, but you're going to filter out your children's noise. You can hear them, but you're still not going to hear them. And you're going to pay attention, and your focus is going to be on the driving so that you don't hit the car in front of you. So that is, your brain is processing information coming from everywhere and, trying to make you function of driving the car safely. Okay, so that means making sense of information, only what is required right now at this location in this context, filtering out the extraneous information. And when it comes to our children, even whether it is a child with CP or a child with Down syndrome or a child with muscular dystrophy, take global developmental delays, and then take autism, which is 1 in 54, the rate of occurrence right now. So we see so many of these children, all of these neurodevelopmental disorders. We have to remember that sensory integration affects speech, particularly when it comes to autism and children with CP and global developmental delay, the GDD. Speech is very important. We cannot say that, oh, that's a speech therapist's job. Yes, it is their job, but we have to be aware of the link between sensory integration and communication. We have to think about the link between sensory integration and cognition, so that we can, plan better intervention, design better activities. As Dr. Sapna already showed a few. That was very nice of her. So this is a quick pyramid. If you see, this is a pyramid of learning. It is very old, and it is by Williams and Schellenberger. I love this pyramid. The only thing is that it shows 7 sensory systems at the blue level in the bottom. And nowadays, since the last few years, we think of us having 8 sensory systems. So the 8th one is interoception, not necessarily the last in order, but interoception is basically, how do you feel? Are you tired? Are you thirsty? Are you hungry? Emotionally, how do you? Don't you feel very well? Did you get enough sleep? How do you feel connected with your own body? Because if you're not very well connected with your own body inside or innately, you cannot connect with the exterior world in order to function appropriately. So that's where interoception comes. Toileting, feeling that pressure in the bladder and the bowel. So going to the washroom. So interoception is again a large topic by itself, but I just want to clarify that now we think of sensory systems as not 7, but 8. And if you look at the bottommost foundation, it's the blue, the tactile, the vestibular, and the proprioception. These 3 are the main systems that we focus in therapy, at least I focus, in addition to the visual system. And then from there, the foundation goes on to how does the sensory motor development occur. It emerges from the sensory systems, from the workings of the sensory systems. From there, we get perceptual motor development. We can go through all the components. We don't have time right now for this short webinar. But look at everything, the postural adjustment, the eye-hand coordination, everything that was covered in the previous presentation. And then the last 3, the top of the pyramid, is the activities of daily living. That is our ADLs, the academic learning, or learning of any sorts, I would say. But academic learning becomes important because every parent wants a child to go to school and learn. and then behavior. So age appropriate behavior and a social environment. So these three are the main, components broadly that, the child is in therapy for: ADLs, behavior, and learning. And we cannot go to the top unless we address adequately the bottom, unless we have a strong foundation. If the foundation is weak, we cannot go to the top components of sensory motor development, perceptual motor development, and then the cognition and intellect, which is the three components of ADLs, behavior, and learning. As I said in the previous slide already, the big three senses are the tactile or the touch, the vestibular, the proprioception. Dr. Jean Ayres called them the power senses or the big three senses. Without these, the motor control would be affected, the motor performance would be affected. And using these three senses as an infant, as soon as a child is born, in the earlier weeks of infancy, in the earlier months of being a baby, the child uses or relies heavily on touch, vestibular, and proprioceptive senses to explore, experience the world around them. And again, we do that all through life, but as a baby, this becomes very important. So why it is important? Because I do get many parents where the child is just left there. There are no toys. And yes, this happens even in middle class homes among educated parents. There are hardly any toys. There is nobody to engage the child with or talk to the child. There is nobody to provide early stimulation, what we call, to the child. So then, that's EI, the early intervention, which can be done right at home for any child. It does not have to be a child with special needs. Every child needs early stimulation from the family or from the parents in simple ways, and addressing these three sensory systems. So, and again, for me as a physiotherapist, why this is important, because I come back again to Dr. Sapna's presentation, that these big three sensory components or sensory systems relate to weight bearing and weight shifting. When we weight bear and weight shift, we are harnessing the tactile, the vestibular, and the proprioceptive systems. So now think about any functional activity. When we think about functional activity, a simple activity like just picking up, a pen from the floor, or walking from one end of the room to other with a heavy load. Think about any simple activity, which, there would be infinite activities that you do throughout your waking time. Think about which sensory systems, come into play. So for any functional activity, you need movement of the head. You need movement of the body segments, right? For reaching, I need to move. So again, movement of the body segments. You need upright posture. If I'm sunk or slumped into gravity, I can't really, participate very well. I can't really execute an activity. So I need upright posture against gravity. I need balance. I need attention. I need bilateral coordination. That is, how do I use two sides of my body together to hold an object, to pick up an object, or even when I go cycling, how do I use two legs together and keep my trunk upright and hold on to the handlebars, in order to cycle. Eye-hand coordination. How do I eat my food? How do I turn pages of my book? Or even, how do I pick up things and, arrange them properly somewhere where I'm asked to. Again, this is not an all-inclusive list, but all these components that I've mentioned relate to the vestibular system. Okay. Now, proprioception, the three subcomponents of proprioception that I can think of is body awareness, body spatial awareness, and force gradation. Body awareness is, we as therapists are very responsible in educating parents. When I just open my mouth, body awareness, the parent will say, my child knows all the body parts. Mere bachche ko sab kuch aata hai. And then they start, show me your head, show me your shoulders, show me your hand, show me fingers. I like to educate parents. That is called labeling. That is not body awareness. Body awareness is, how does the brain perceive the parts of our body, or how am I aware of the relationship of body segments right now? So for example, if I'm sitting on the stool, without looking at, I can tell you that my hips are bent, my knees are bent, my feet are, maybe one foot is touching the floor, the other foot is not touching the floor. I can tell you that even without looking at my legs. So that is called body awareness. Body spatial awareness. How far is my body from this table, How far is my body from, this wall is closer to me than this wall, the body spatial awareness. And then the force gradation. So force gradation is another thing we need to understand. We all have an optimal level of force which we use in doing every activity. So I use a very light force to pick up this light object, and then I use very light force to put it down. But if I put, if I utilize heavier force, I will bang the object. Similarly, if I'm picking up a glass full of water, I'm using, certain force to bring it to my mouth. But if I use more force, either, the glass will miss the target, or if I use more force to put the glass back, the water is going to spill. So in real life, we use force gradation all the time. If we use more force than necessary, it will be a disaster. If we use less force than necessary, the activity will not be completed or executed properly. So we have something called optimal force, that is not too much and not too little. And classic example I can give you, many gross motor examples I can give you, but fine motor I'll give you because I do writing also. So in writing, if a child is holding a pencil and writing with too much force, the impression of the letters will even, you can see on the next page when you turn the page. Whereas if the child uses less force, then the writing will be very light and maybe not very legible. But if the child uses optimal force, it is not only efficient for the child, but the handwriting also comes out to be neater and legible. So, that's an example of force gradation, which we use all the time in our life. And as physical therapists, we really need to be aware of. So, and then the tactile system we need, we touch things, we touch people, we touch objects. Visual perception is very different from the 20/20 vision or that visual acuity that we call. Visual perception is how does the brain process visual information coming from the environment. That is, again, there are many subcomponents to visual perception. OTs are great at it. I also address them, when I'm doing my intervention. But some of the examples I'll give you, visual perception is, again, in in the room right in front of me, some objects are in the foreground versus the background, or the room is much lighter or much brightly lit than outside, it's getting dark, for example. So visual perception also has many components. Okay, interoception I already spoke about. It's our inner feelings. How do we feel, and how do we feel connected with our inner self? And then there's the auditory system, the olfactory system, that is a sense of smell, which goes with the sense of taste. So olfactory system is our most primitive system. It is actually meant to protect us because we smell the fire before we actually see it. We smell the rotten food before we actually bring it to the mouth. So once we smell that it's rotten, we don't bring it to our mouth. It protects, the sense protects us. And then smell and taste go together, which are very important in eating and feeding for our children. A lot of our children have issues with eating and feeding, and touch, smell, taste, and many other sensory systems are important in that. So as a PT, some of the therapeutic activities that we do, sit to stand, stand to sit. We do prone weight bearing on a ball or on a rocker board, wobble board. We straddle on a bolster. But what my message to PTs is, be aware of the sensory components while you're doing these activities. Motor components, yes, whether the child is weak or whether the muscles are tight or what is the child doing, but be aware of the sensory components also. So for example, stand to sit. Dr. Sapna already mentioned that, sometimes they plop. Even older children just plop rather than controlled sitting, they plop. They are not aware of force gradation. Okay, so they can't come controlled standing to sit. Straddling a bolster, watch whether they're having trunk rotation, whether they're crossing midline. These are all again sensory components. If we are working with them on a wobble board or a ball in any position, do they weight shift symmetrically? Are they balancing symmetrically when we do the weight shifting? How are the head and body segments moving? So these are just some of the examples I can give you how to watch for the sensory components. And then secondly, we can actually enrich our activities, or the games I would call, by including toys for reaching, puzzles for fixing, bean bags or anything like that for throwing at a target, picking up water-filled bottles. There are many activities, and they don't have to be gotten from, especially from the market. You can find them right in your environment if you think enough. So that way our activities become sensorically enriched. We become aware of the sensory components. If we cannot treat them, if we think that we don't know enough, we can make a referral to OT so that the child benefits. And also these activities for us in therapy become meaningful and fun. What are the sensory flags that I see sometimes? Again, everything that I've spoken about, or Dr. Sapna has covered all this well, but asymmetrical posture, I only don't look at weakness on one side, but I also think about the vestibular system. I look at midline issues, balance, fear of movement. If the child is fear of stepping down or climbing up, it is just not fear, it is gravitational insecurity, which is related to the vestibular system. Body awareness, body spatial awareness, I already spoke about. So how, when I ask the child, come sit here on the bench near the table, the child will come to the table, but most likely the child will not sit on the bench. He will sit to the side of the bench or even fall because their body spatial awareness is compromised. Okay, so these are my observations. I observe how do they use hands. How is the bilateral coordination? How is the eye contact? Because eye contact again is related to the vestibular system. And in babies, eye contact is the first form of communication, or I say the first form of speech, I would call, but communication is a better term to use here. So I'm always looking for eye contact, visual perception, speech issues, whether they're verbal, non-verbal, age appropriate. And even if they're non-verbal, do they understand our instructions? One step, two step. If they are verbal, do they say only one word, two words? Can they say a short sentence? Again, age appropriate. I don't compare them to age appropriate. I discourage parents from that. But it's at the back of my mind, it's always going on that, this child is not doing the things the way they should be. Head shaking. So, Dr. Sapna went through all those stages of GMFCS. So many children right through the, from the upper level, the higher levels of the GMFCS to the lower levels, you will see a lot of children because they're movement deprived. You will see things, constant head shaking, restlessness, constant, impulsivity, like, they try to reach or bang constantly. Some of them are constantly humming, constantly making noises, constantly singing something. So all of this, parents sort of wonder that they are being taken for therapy, but what's happening? And then, they get referred to me because I'm a PT and I still do sensory integration. So then I combine the NDT-SI, which I'll show you in my videos very soon. So therapy implications, what I have is performance of any movement in isolation is not accepted in today's world. We have to think about function. We have to let the child interact, explore, get interested in objects, people, and the environment to address all the sensory issues and the sensory components. And for that, we have to be providing opportunities. We have to plan opportunities for the child, because if a child is deprived of opportunities, he or she is not going to learn much. Okay. So incorporate into sessions fun to motivate the child, to bring in attention. If you don't offer something interesting, attention is not going to come in. Most parents, ask me, how can I improve attention? And sometimes I don't have words to answer them. I only show them how to. I really don't have any ways to describe them. Design activities in such a way that the child doesn't think of these activities as punishment. The child doesn't think of our therapeutic activities as punishment. Provide movement in every activity. So, just don't lift your arm, lift your leg. No, provide the entire body movement in any way, whether in prone, whether in sitting, whether in, while standing, crawling, kneel walking, but provide movement as much as possible. Provide challenging postures and challenging movements. Provide visual references. So all the objects that I said, throwing a bean bag, showing flashcards, showing picture cards, showing animals, visual references is a critical part of making our therapeutic activities meaningful. And then hand materials, even if as PTs, working on fine motor is not our goal, our clinic should have a large inventory of items, even from waste materials. In my clinic, I have things like, not only sand, kinetic sand, but pista shells. I have bubble paper that comes in the Amazon boxes that, I'm ready to throw. I use it in the clinic. I have curtain rings that when I change my curtains, the older curtain rings were useless for my home, and I brought it into therapy, to touch, and I designed a whole activity with that. So think about hand materials, even though they are not your goals as a physiotherapist. So finally, I would like to say pediatric PT is an art. You need to be creative, but then that art is rooted in science. We have to think about what to do, when to do, how to do. And this what to do, when to do, how to do, why always changes, maybe session to session, maybe week to week, maybe month to month. I will just show you a very quick video and then I will end what goes on in my clinic. So I'm going to skip a little. This is of course an adult being treated, so I'm going to skip this. Now this is an ankle patient, but again here the sensory, I would think of it as rhythmic movement, timing and coordination. Now this is a child with cerebral palsy. He is walking around. And I'm still working on the kneeling, because when he came to me at age 7, he was all tilted like this. So the meaningful activity I'm doing is he is not able to kneel, tall kneel with good alignment. So, meaningful activity. This is a child with autism who is engaged in fishing. Again, eye-hand coordination, balance. This is another child with cerebral palsy. So I'm doing the NDT facilitations, but I'm also providing a sensory input of ball tapping. It is fun for him. It is motivating for him. It brings him into upright posture. This is a baby, again, providing a visual input through a mirror, again, combining NDT, SI. This is a child with spastic diplegia who's climbing a ladder, who's climbing a dynamic ladder, not independently, with help. This is, I would call, pure NDT facilitation. However, I would also like to talk about sensory components that come here, because actually there are toys on that wheelie thing that the child is looking at and talking about. So I'm just doing some gait training relying heavily on NDT rather than other approaches. And okay, so Dr. Sapna already spoke about how we do prone weight bearing. And even here in an exercise class, a fitness class, you can talk about sensory components. This is my favorite sensory activity, I would call. You cannot say it's not motor though. Swinging and throwing bean bags at a basket or a target. This is an adult patient with traumatic brain injury. Again, there are a lot of sensory components I've brought in. This is a patient with supranuclear palsy. So sensory components of picking up, cups and then crossing midline. The same patient who's engaged in trunk rotation, resistance work, addressing the core, addressing the balance. Okay. And this is what I call a circus. Children in my clinic, we call it as a circus. And then here one child is on the cart, the other child is pushing the cart. Again, heavy work, proprioception. So physiotherapy or physical therapy, it's an art based in science. I would encourage a lot of PT students to take up pediatric physiotherapy. It's very creative. It is fun. It is constant thinking. It always picks my brains. So I love it. Thank you very much. Thank you very much for your patient listening.
Thank you so much, ma'am, for your wonderful presentation. And I can say it was wonderful.
Thank you. Thank you. Thank you.
Dr. Reena, Dr. Nandita, Dr. Sapna, if you want to ask any question regarding this.
Ma'am, I have one question.
Yes.
Ma'am, what is the unwanted जो हमारी ये जो sensory information होती है वो किस level पर filter होती है in the nervous system? At what level of the nervous system it is being filtered out?
Okay, so generally the higher levels, generally the orbitofrontal cortex. Okay, but we cannot say that's not the only level. It can even happen at the subcortical levels also. But the orbitofrontal cortex is basically, an inhibitor, right? In its role as an inhibitor. So whatever you do, even motor action, if a child is very impulsive, I can say that the higher cortical levels are not functioning very well or not being executed very well. Okay. And so now one thing I want to clarify. So when we say sensory integration, this does not apply only to a pediatric or neuro patients. all of us also have certain sensory integrative issues. Like I may not be able to filter out as well as you, or vice versa. Or even me, the same person, today I may be well able to filter out, but I may not be well able to filter out tomorrow. But that tomorrow, that level could also be based on my sleep and my fatigue and my other levels of cognitive demands on that day. We all have certain sensory integration issues, but our issues fall within what we call, SI therapists call it as a normal bandwidth. Our children or our patients fall outside this normal bandwidth, meaning that it interferes with their function. For us, we are still able to function. So I may not be able to filter out tomorrow very well, but I would still be able to complete my day's work. Okay. But mostly, yes, the higher levels. Yes.
Okay, ma'am. Thank you.
Yes.
And it
You're
was
welcome.
great
You're
hearing you,
welcome.
ma'am. Your experience speaks.
Oh,
And
thank
it
you.
was wonderful examples, ma'am. Your presentations was covered with wonderful examples. Thank you so
Thank
much.
you. Thank
Thanks,
you.
Dr. Chirag, for
Thank
giving
you.
us this opportunity and hearing ma'am.
Yeah, ma'am, that's what I was telling, that ma'am has presented so wonderfully that every topic she has included in this presentation.
Yes, sir. True.
Dr. Nandita.
Yes, sir. I'm very impressed with the setup ma'am has already built up. It's very inspiring to see all the setups which you have been put more effort on it, ma'am. Thank you
Oh,
so much
thank you.
for your kind
We,
sharing of knowledge.
thank you. I don't know about Dr. Sapna, but I actually cover information. I teach courses like this for a day, like 6 hours. So you can imagine my plight, to cover 6 hours of information into 20 minutes, so or 30 minutes, I would say.
No, ma'am.
So,
Indeed, it was a very, very wonderful session, and I learned a lot.
thank you, Dr. Sapna. Thank you.
Actually, I'm pursuing my PhD right now, and I'm working on kids with cerebral palsy, and I'm working on their sensory component. That's why
Feel,
I added.
feel free to call me. Feel free to call me.
Ma'am, if you can, yes, I need your mail ID and your number, so maybe I can take it from Dr. Chirag
Yeah, or
if he
my
has not.
active Karya, my clinic is there on Google. I'm on Facebook. My name, if you Google, you can get it. Because I nowadays my caseload comprises mostly children with autism, hyperactivity, writing issues, everything. However, I do get referred a lot of children with CP, traumatic brain injury, hemiplegia particularly, and they're already getting therapy at a very wonderful place everywhere, and they are also committed, very good therapists. But those therapists send me these children. इसका कुछ करिए और कुछ करिए आप कर सकते हैं तो. And when the child comes to me, sometimes when I'm like, अरे ये 8-10 session में कितना improvement हो गया, कैसे हुआ? I just design activities, yes, based on clinical reasoning, but sometimes we can't really even explain our whole clinical reasoning very much. We just keep doing things, a lot of trial and error based on the past experience, and then we get outcomes, and then actually I think back, ye hua tha, aise. So I just want to educate PTs that have some awareness of sensory components. You can get better outcomes for your patients, because parents are really frustrated everywhere, and parents are running from pillar to post. They go to PT and OT and speech, and besides the metro cities in our country, particularly the smaller cities don't even have much to rely upon. So that's a dilemma. So whoever we are available. I mean, when I opened my clinic in Bangalore, there were no sensory integration clinics. Maybe there was 1 or 2, but they were not very well known, or parents didn't know the importance of sensory integration. And my clinic is not that old, it's only less than 9 years. And now parents have become much more aware. So, and now there are many more clinics who are doing great work. And I'm glad, because then we can, service more and more children. Ours is a country with a large population.
True, ma'am, true. And even in our practice, we are also seeing that all our sensory issues and all.
Yes.
So that's why we are addressing them. And now I'm doing it, you can say a study on that also.
Oh, great, great. I would be more than happy to help, because I always collaborate with, colleges and universities in Bangalore. Whatever help I can give them, that's fine.
Sure, ma'am. I'll also visit your clinic whenever I
Sure,
come to
please.
Bangalore.
Anybody who comes to Bangalore, please visit my clinic. All clinics are great, but my clinic is, my baby. It's my passion. I returned from the US after so many years, and I started this from, like, you can say, ground zero. Totally my ideas, and I did bring a lot of equipment from the US, the smaller equipment, but the bigger equipment I got them custom made here with my carpenter and upholsterers, and on based on the needs of my children, I kept on expanding. So sensory integration unfortunately requires a lot of equipment also, which is also a limitation.
Yeah, ma'am. I actually in Delhi, IPH is an institute for physiotherapy.
Huh.
So there also they have set up the sensory integration unit, and that is also wonderful. I have seen, because
Yes,
I'm
yes.
passed out from that so that comes under OT, but still
Mhm.
unit is good.
Good. No, even Dr. Sapna, whatever we showed
Sir,
her in
even
her photographs,
yes.
that's great. That's great.
I wanted to add in that only, sir,
Uh.
we are in DIPSR University, that is
Uh.
Delhi Pharmaceutical Sciences and Research University. In
Mhm.
our physiotherapy OPD, we have started this special pediatric physiotherapy unit, and that to be in a government setup. So that,
Yeah, yeah.
like you can say, it is free of cost. The children
Yes.
get treatment, and we have
Yes.
all the like I have tried to incorporate all the equipments, try to have or every kind of you can say, ma'am, different type of swings are there. I tried whatever I can try.
Whatever.
I tried in
No,
that
that's
government.
very good, because and particularly in a government setup, because people without money, where will they
Exactly.
go? And
That is the important thing.
that is important. Now we need to really get ready an army of young therapists who are willing to work, in pediatrics, have an interest in pediatrics, because it is so much fun. And in pediatrics you can create equipment out the number of equipment. I have about dozen swings in my clinic. Dozen. Okay, out of the dozen, 4 or 5 I have made them with my own hands.
Yes.
Okay, and out of raw material, idhar se liya, udhar se liya.
Yes, ma'am. Even I
From
teach
bed
my
sheets,
parents.
from bed sheets, some karate belts. Both my own children are adults and they are black belts in karate. So all the karate belts are with me. I created equipment out of karate belts, So we need to be creative, and we need to bring in, a lot of pediatric therapy is where we have a shortage of people in our country. It's very unfortunate. Very unfortunate.
Ma'am, the basic thing is as I am passed out from IPH, there was only a sensory integration unit that was a part of OT. We were not allowed to go over in that unit. Only patients and occupational therapy students were allowed.
So
Actually, sir,
okay.
sir, now this MPT pediatrics has started, and this is how they have changed the entire scenario. Now this OT
But
and
ma'am,
PT
still
concept
in
has.
North India, it is not started.
No.
That is the
Sir,
main
from next year, DIPSR University is going to start with MPT pediatrics also. This is what I'm telling you. Next year.
So here is the thing. In Bangalore, maybe because I'm senior, I have more than 30 years, 32 years of experience now. I've returned from the US, maybe all of this, my age, maybe. But in Bangalore, OTs reach out to me. Ma'am, iska kya karna hai? Ma'am, aise karo, waise karo. So the thing is that, like in US that I have worked, let us be friends with OTs rather than being, let's complement each other. जैसे अभी OTs therapeutic listening बहुत करते हैं, at least 1 or 2 OTs in Bangalore are doing it, and I decided not to do it because there's a lot of investment in that, and I'm like, I'm not going to do it for personal reasons. But अभी जो भी बच्चे को therapeutic listening चाहिए, I refer that OT, कि आप ओके मेरे पास आए या ना आए, उसके पास भी जाइए. And she is also very friendly कि हाँ मैम आप 2 सेशन देख लीजिए, मैं 1 सेशन ऐसे कर लूंगी. So let's work together. So coming to Dr. Saurabh or whoever was speaking here, Academy of Exercise, or Dr. Chirag,
this side, Dr.
work
Chirag.
together. Dr. Chirag, yeah. So let's work together, because rehab is PTs and OTs working together. Again, speech also, because cognition is addressed by speech therapists as well as OTs. Okay, not much by us, but let's work together. I think rehab is more successful in a country like US and Canada is because
So, good evening to all of you. Myself, Dr. Chirag Verma, Director and Chief Instructor at Academy of Exercise Health and Therapy. today we are having the last colloquium, sports colloquium of second International Web Physio Summit 2021. Last year also we had this summit, and this year we are having this summit organized by Academy of Exercise Health and Therapy in collaboration with Assam Downtown University as an academic partner, as well OsteoPro, the Osteopathy Association of Italy, and European Register of Therapists as an academic partner of this International Web Physio Summit to 2021. So we had 5 colloquiums previously. Like one colloquium was just 1 hour before this sports colloquium right now of Peads. In the morning we had cardio colloquium. Yesterday also we had a neuro colloquium, gynae colloquium, and ortho colloquium. Last year also we had 4 colloquiums, but this year we have added 2 colloquiums, that is Peads and gynae. And last 5 colloquium in these 2 days we had organized. That was wonderful. Even our all speakers and national and international speakers had a very wonderful presentation. So we are hoping that this session, this colloquium, sports colloquium, we will be having a wonderful session also. In this we will be having our chairperson, Dr. Vinay Jagap, is a professor in physiotherapy, PhD in physiotherapy, as well as our co-chairperson, Dr. Vinosh from Intli University, Malaysia, is a lecturer over there, as well as Dr. Prasanjit, he is a assistant professor at Women College, Guwahati. So today we'll be having 4 speakers in this colloquium. Dr. Parth Trivedi, BPT, MPT, PhD, and he is a lecturer at CM Patel College of Physiotherapy. And second will be Dr. Sitaraman Sundaresan. He is a director at 33 Intact Clinic. And again, the next speaker is Alex Silva Gracia. He is a PT, BPT, DPT, and he is from Peru, South America. Prasanjit Bhattacharya is HOD in charge, Assistant Professor, Department of Physiotherapy, Assam Women University. And Dr. Vinosh Kumar is a lecturer at INT International University, Malaysia, and is a member of Malaysian Physiotherapy Association as well. And Dr. Parth is our speaker right now. Is MPT Ortho and Sports, PhD, and lecturer at CM Patel College of Physiotherapy, Gandhinagar, Gujarat, and a freelancer peer reviewer at Engo Publications, and as well as he is academic editor, Asian Journal of Orthopedic Research, and is a reviewer at Journal of Harmonized Sciences. Next speaker will be Dr. Sitaraman Sundaresan. He is MPT Sports, CSRT USA, and Director 33 Intact Clinic. Our next speaker will be then Alex Silva. He is a Peruvian physiotherapist, creators of Hands Pro tool instrumental manipulation, and a creator of Artric Pro tools to joint manipulation as well. He is a postgraduate training manual orthopedic therapy, postgraduate degree in clinical neurodynamic, as well as postgraduate degree in research in health sciences, instrument handling certifier with Hands Pro worldwide, and is a master in osteopathic techniques of the locomotor system, postgraduate in neuromuscular taping, postgraduate in fascia manipulation training. He is a director at Physio Life. He is a university professor at Universidad Periuna de Ciencias Aplicadas. This is a Spanish word, I think. National and international speaker in the area of orthopedic manual therapy. As well as our next speaker will be Rodrigo Agustin Aray. He is a licensed kinesio and psychiatry therapist from Argentina. He is a CEO MPT from Australia, XPS from USA, Mulligan Concept, Mackenzie McKennell Education, and he is a FMS instructor, functional movement screening instructor. He is a Exos Educational International Consultant as well. So he'll be taking the topic of soccer players, how to perform prevention strategies in professional soccer team. Alex Silva will be taking hands-through intervention manipulation in sports physiotherapy. Dr. Sitarman will be taking foot pressure analysis and mapping for runners. And now Dr. Parth will be starting. He'll be taking potential usefulness of virtual reality in sports rehabilitation. I would like to request Dr. Abhishek to welcome Dr. Parth.
Nice. Good evening, sir. And thank you for being a speaker for our evening conclave in sports. Now I would like to invite you, sir, to please represent your topic. Thank you so
much. Good evening. I hope the screen is now visible.
Yes, sir. Your screen is visible.
Great. So my grateful thanks to Academy of Exercise, Health and Therapy for inviting me as a speaker in Second International Web Physio Summit 2021. A grateful thanks to Assam Downtown University also for inviting me for this summit. So today, as I'm actually traveling, and in my way, I'm having a presentation, and unfortunately, there are some issues with my laptop camera, so I'm not visible. But luckily, there are no issues with the presentations, so we are able to continue this. The top my talk is based on potential usefulness of virtual reality in sports rehabilitation. Yes, so we will be discussing about basically how virtual reality is the game changer in sports rehabilitation now, because we are now moving on towards technology in every aspect, whether if we consider defense or our social activities or our financial activities and health profession. Also, we are moving slowly and gradually towards technology, and technology is now being an integral part of us everywhere. So how the virtual reality can help us in sports rehabilitation? The concept of virtual reality is now being researched in many areas. It was pioneer researched in neuro rehabilitations, and now gradually it is gaining peak up in sports rehab also. So how we can be useful about virtual reality, and how can we use, and what are its benefits, what are its strengths, what are its weakness, what are its opportunities and threats. So we are going to discuss that. So before we move on, we would be seeing what is virtual reality, what are the pros and cons of virtual reality, and types of virtual reality, and SWOT analysis in sports. So basically, virtual reality is nothing but creating an environment like you are living into it. Yes, so it is a technologically driven environment which creates you, and which you are into that environment. Yes, so let us go into the Jurassic World Park ride right now. I always have a tendency to get people into the virtual reality when I'm into the delivering this lecture. So let us see what happens into this wonderful video. So I'm trying to create a virtual environment of a jungle wherein you can see beautiful trees, beautiful landscapes, birds roaming around, huge eggs surrounding you, and suddenly some dinosaur comes, and you are trying to experience this wonderful technologically driven movies. Yes, so just imagine, like, it was so beautiful. Like, if you are having this headset and you are doing your exercises, how great it would be for an individual to do exercises. It won't be boring. Yes, so you can see this bee harassing us, yes, right now. So this is such a wonderful atmosphere. We are enjoying rains, we are enjoying, and we are trying to get into the virtual world where we are actually physically we are at some other place. You see this bee is harassing you and the bee is disturbing you also, then also you are moving on, you are seeing, see, if she so this is the virtual world which I'm talking about. Beautiful birds. So this kind of virtual world will definitely change your mindsets towards rehabilitation. Yes. So see, one of the huge sculpture is coming to meet you now. Yes. So you have never seen a dinosaur and now you are seeing a dinosaur greeting you. So just imagine. Yes. See, you can count the teeth of the dinosaur also. Yeah. Such a wonderful teeth and such a wonderful tongue the dinosaur has. And just imagine, we are supposed to give rehabilitation, or we are supposed to use this world for rehabilitation purpose. So we can modify these kinds of. Uh, this is just for an example that we are creating a 3D environment uh, of a virtual world, and this kind of environment is practically just created for rehabilitation purposes. That is nothing but virtual reality in the rehab purposes. So basically, what are we doing is we are creating an artificial environment. Yes. So we are technically creating an artificial environment. Yes, that is with a software, and then it is presented in a user which believes and accepts the real, it is like in real environment. So this is very, very important. So technically you are creating an environment with the helps of certain softwares which is similar to the soft environment which you are going to be. So for an example, the cricketer who wants to practice something against, or a specialized technique against a special bowler, you create an environment in that way that the person or the bowler, opposite team bowler, is going to ball the same way that as he or she is bowling in the real match, and then the batsman is going to practice it. So that is why you are going to create an artificial environment in the way the real environment is there. So it basically is experienced through our five senses, and one of most common is sight and sound. So these senses are very much helpful in understanding the artificial environment as a real environment. Yes. So one of the commonest virtual reality in sports would be Hawkeye images, or ultra edge images, or a hotspot images. So now, how does this work? So you would have seen that, now with the IPL matches and international cricket matches, the on-field umpire, if he or she is not clear, or the review system, if the batsman wants to review, or the fielding team wants to review, what do? They go for the reviewing purposes for the third umpire. Yes. And then the umpire says, I want to go for an ultra edge, or I want to go an Hawkeye system, or an hotspot system. So basically, these are nothing but creating, Hawkeye is specifically creating an artificial environment in the way this how the ball is pitched and how the ball would have gone if there was no leg before. So basically, Hawkeye system works like you have 6 to 7 cameras setups in different parts of your ground, and those camera, once the ball is being released from the bowler's end, those camera with the motion sensors and the speed sensors, they would track the ball from the throw till the end. So that helps us to identify whether the ball, if there was no leg before, how the ball would have traveled, and that would help us in identifying the judgment. So that is why this is nothing but an virtual environment creation for understanding and getting a clear picture. So basically, Hawkeye was developed by Pearl Hawk. Um, so that is why it is known as Hawkeye systems. So you have various kinds of, it is not just Hawkeye is not nowadays used in cricket, it is used in various sports like tennis, footballs, and everywhere. So now how can we use it for rehabilitation purposes? So as I said, that we are creating 2 or 3 dimensional environment which is emulated with the pictures also and with the video recordings also. So basically, you are asking an athlete to be mentally present, even if he or she is not there physically. Yes. So if an athlete or wants to go, wants to do a practice at certain location where he or she is not going to be physically not possible for him to go there, so basically like he or she interacts with to the environment which is captured by these sensors and providing a feedback. Clear? So similarly, I will go with another virtual athlete paragliding video. Yes. So this is like creating a virtual environment for a paraglider. Yes. It is and a skater, ice skater. So we are basically creating this virtual world, and we can ask that, you can practice, you can jump now with this. So the sports person gets an idea about how the virtual world is and how it can be used. So this is kayak. You can see the board and the kayak moving the way it moves in real life. So we are creating this 3D environment or the virtual environment. Yes. So this way, basically a virtual environment can be created. And how we are basically ranges. So you are seeing one of the image in my slide also. Basically, it is a headset image. So it ranges from an headset to an high-end systems of computers. So where a user is immersed within a virtual environment with an high-mounted devices also, and lower cost devices are also there, like flat screen monitors. And it was first basically sold by VPL Research, and then now gradually with advancement in technology, we have multiple companies. One of the companies, Nintendo V, which is going, you know, supplying good virtual reality headsets now. How can we basically have virtual reality? We can have purpose designs and commercial gaming. So purpose designs are basically used for rehabilitation purposes and treatment purposes, where the specific type of exercises domain is being used for rehabilitation purposes, and commercial gaming purposes are used for your entertainment purposes. So basically in rehabilitation, you have purpose designs virtual reality sets, and you have these kinds of research which shows that uh, in 2002 Rutgers University has given a comparison like what are the benefits and challenges of virtual rehab, and they had basically divided into neuromuscular, post-stroke, and cognitive and telerehabilitations. So this is post-COVID era. It is one of the emerging trend which our physical therapists need to focus, because looking into the COVID era and post COVID changes, we can create a virtual environment, and our physical presence can be replaced by a computer driven devices. So that can be a helpful, and that can aid, that cannot replace us, and that cannot definitely give the what we say, the perfections what a physical therapist gives, but they can help us in rehabilitating. So this is way you can see this how a wonderful virtual set is created in a computer's in a flat screen monitor, where you can see a game has been created like a Mario game, and sensors are there on the patient's wrist, or see. So if you want to move on right, he is doing wrist flexion. Yes. So if you want to move on left, he is doing wrist extension. So these kinds of uh, games, just imagine, like, it would be so easy and it would be so encouraging if we can use these kinds of gains for a patient to for a rehabilitation purposes. Yes. uh, Later on in the presentations, I would be also showing that how we generally use biofeedback devices. It is a type of virtual reality. We are not able to create full-fledged virtual, but it is a type of virtual reality. So with more force, concentric force, he is asking the is getting the character to jump on that. So this is where we generally create a virtual environment. So basically, what are the strength? It actually allows an individualization of training. This domain is like you can tailor figure the games, and you can change accordingly what an athlete wants. So you can have a specific athlete for game for a runner. You can have specific games for a jumper. You can have a specific games for javelin throwers, for cricket players. So basically, it allows you for individualization rather than getting it a single set of exercises for each and every athlete. It can be applied in everyday settings, and when traveling, lying in beds, and working, it actually engages the athlete or the participants, and that helps in better outcomes of the uh, rehabilitation. It gives you a good biofeedback. Yes, so it helps not the therapist also, but it helps the patient also understanding what actually is needed and how is it he or she attaining it or not. It designs and manipulates freely an infinite number of procedures, so you can have multiple number of challenges, not only just one, like having only 2 kgs of dumbbell or 5 kgs of dumbbells and doing the same movements again and again. So you can change and manipulate things also, and it actually competes and train with other athletes around the world. As I said that, you can have, if you want an athlete after an injury, if the athlete wants to go back to the game and sports, return to the field, you can, before he actually returns to the field, you can create a virtual environment and accustom the athlete getting into that environment before he goes physically there. So this is what we do in our therapeutic setups for lateral epicondylgia. This is one of the video which shows that we have uh, us just we have this setup, and it actually this is a biofeedback setup, and this are the EMG electrodes which measures the muscle amplitude, and based on the muscle amplitude we set up certain frequencies and ask the patient to do the similar kind of game which we had seen in our previous slide. We ask the patient to do wrist extensions and flexions, and the patient does with the help of this MyoPlus Pro machine. So this is basically an EMG biofeedback. It is not purely virtual reality, but yes, it is a type of virtual reality which gives you a biofeedback. But what are its difficulties? It becomes very difficult uh, once you go and achieve a biofeedback, but it needs to be a realistic also. Like, you cannot have false environment and then get an individual into that. So you practically need a realistic approach towards a virtual reality, and then VR applications basically capture the motion of athletes in real time, require massive computational powers also and bandwidth issues. So in a country like India, where you still face bandwidth issues and network issues, it becomes very much difficult to have these kinds of computational setups and bandwidth uh, issues to overcome. So yes, these are two weakness, but we can overcome with these weakness also. But what are its opportunities? As I said that if I'm sitting over here and my patient is in some other state, and if I create a virtual environment from my home place and to another state, he can easily get treatment from that setup. So that is what you can remotely, any coach or a rehabilitation expert can coach it at a time and place of their own choosing. Again, you have varieties of skill decision makings and pacing strategies that optimize utilizations of energy also. And it actually lower levels the perceived exertion while stimulating the enhancing the enjoyment. So you have an enjoyment component also. So basically the athlete doesn't get tired in that. So this is one of the great opportunities which you can have, and they can be employed to you optimize the warm-up procedures, and definitely it helps in diagnosing purposes also. So this is their opportunity, but threat, as I said, it might be difficult for everybody to accustom to it. It may take time. It may take time for others to adopt. It should be cost effective also, yes. And you, once the athlete is there into the setup, he, with the VR set, he gets accustomed to it. You need that he or she does not fall while he's wearing the headset, and particularly has a risk of appearing to a particular grade in connection with the visual restriction, and especially with the head mounted sets. Yes. So this is what a virtual reality in sports rehab can be useful. And uh, it is a new era wherein we use the virtual environment and aid the athlete in rehabilitation purposes. That definitely helps, and you have many researchers supporting the virtual rehab procedures uh, in sports rehabilitation in various fields. So I hope I have given justice to the topic, and the audience is satisfied with the content of the seminar. Thank you.
Thank you so much, Dr. Parth, for having a wonderful virtual presentation. Actually, this summit is also virtual. So you have done your work by showing a virtual presentation as well. And I would like to request Dr. Vinay, if Dr. Vinay wants to ask any question, or Dr. Sitaraman wants to ask any question regarding the presentation, or any participant can ask.
No question, please.
Sir, any comment on this?
Comment. Dr. Parth had done a great thing on this virtual reality. Our sports person and physiotherapist must live with that. He gave a good idea of virtual reality in sports. Definitely, it is. Definitely, it is very good. Thank you.
Thank you, sir, for your blessings to Dr. Parth and to us as well. Dr. Sitaraman, you want to ask any question regarding that?
No, I'm good, absolutely fine. It was a fantastic presentation, Dr. Parth. The insights shown in was pretty much good, and then probably we'll connect offline and then take this forward.
Yeah.
So I think no question from participant as well. And if any question would be there, I will be asking from Dr. Parth after the session of Dr. Sitaraman. So moving forward to the next part, I would like to request to Dr. Abhishek to welcome Dr. Sitaraman, or Dr. Saurabh if available.
Nice. Good evening, sir. Thank you so much to accepting our invitation, sir. Being a part of second Web Physio Summit, I would like to thank everyone, and especially our recent speaker, Dr. Sitaraman, sir, to present your topic, foot pressure analysis for runners. Thank you so much, sir.
Thank you, Dr. Abhishek. Thank you, Dr. Chirag. I will quickly put my screen up for you, so we are aware of what we do. Yeah. So you're able to see the screen?
Yes, sir, visible to us.
Yes, sir, visible.
Super. So to briefly introduce myself, I am a founder consultant at 33 Intact Clinics, and I've been the Indian team physio for the 24-hour World Championship back at France, Jordan, and at Taipei. My topic of presentation today is going to be foot pressure analysis for runners. I will briefly walk you through the basics of the foot and why it's now becoming very, very important for us to use this across onto runners. Right? The foot complex, you prominently see close to about 28 bones with 33 joints and 112 ligaments. And they're controlled back by about 13 extrinsic and 21 intrinsic muscles. The foot is further subdivided into rear foot, midfoot, and the forefoot. Based on these is where we go back to seeing what is the basic set of analysis that we require out for these runners. Okay. The foot and ankle also provides various important functions, which includes supporting body weight, providing balance, shock absorbers, transferring ground reaction forces, which will be considered as DRF, compensations for proximal malalignment, and substituting hand functions in individuals with upper extremity amputations and paralysis. Now, the anatomic structures predominantly on the hindfoot, midfoot, and forefoot that we basically deal with. The hindfoot is composed of the talus and calcaneus, and the talus calcaneal articulation is further referred to as the subtalar joint, which has 3 facets on each of the talus and the calcaneus. Then we come into the midfoot. The midfoot is again based up of about 7 tarsals bones, including the navicular, cuboid, and the medial, middle, and the lateral cuneiforms. And the junction between both of these is termed as the Chopard's joint, which includes the talonavicular joint and the calcaneo-cuboid joint. The forefoot, again, the most anterior aspect of the foot, includes your metatarsals, phalanges, and sesamoid bones. Right? And the articulation of the midfoot and the forefoot forms the Lisfranc joint. The talocrural joint is formed between the distal tibia, fibula, and the talus, which are commonly known as the ankle joint, right? The talocrural joint again becomes the most important aspect when we deal with runners. A pictorial presentation of it from the lateral aspect and back from the posterior aspect. So if you may look at the structures which predominantly comes in on the medial component, which includes out your deltoid ligament, and laterally the ATFL and the TFL joints. When you look at the subtalar joint becomes the most important aspect when we deal with runners. Right? Runners predominantly have a tendency to go in with a landing force that comes, which is again translated back by the GRF. Now, the subtalar joint predominantly takes major of the loading there. Now, the subtalar joint is also the talocalcaneal joint and is formed between the talus and the calcaneus. What happens is why this joint is becoming very, very important for runners is predominantly because this determines whether the runner is predominantly landing with pronation or is landing with supination component which comes in through. Now, the subtalar joint also allows inversion and eversion of the ankle and the hind foot. That's the reason why when we look at an athlete when they're standing in from a posterior view, we can make out what portion of the foot is going into pronation and what portion of the foot is going into supination. Right? Clear until here? So we move on.
Yes,
The
sir.
mid-tarsal joint again comes in, which is also called as a Topaz joint, comes formed off by the talonavicular joint and the calcaneo-cuboid joint. Right? Though this becomes very relevant in anybody who's not into running per se, the uniformity and the usage of the mid-tarsal joint in a runner, unless until he or she is not injured, is not of much predominant relevance. The TMT joint, which is also called as the tarso-metatarsal joint complex, also known as the Lisfranc joint. This becomes the most important aspect when we're looking at foot scans, as I walk through the scans in the upcoming slides. Right now, this complex divides the midfoot from the forefoot. Right, so when it divides the midfoot from the forefoot, what we need to see is where the collapse of the arch is happening. Right, the collapse becomes very, very important when we are dealing out with the Lisfranc joint, because on the Lisfranc joint is where we actually can classify an athlete as either having a flat foot or a guy with a high arch. Right, so the concept of introducing an insole or a stability shoe becomes very, very important. This is the Lisfranc joints complex. Now, on the pictorial view, if you look at the plane of the movement and the motion that these joints come in through, the TC joint comes in with a hinge type of a thing, and it comes in on a sagittal view of movement and causes dorsiflexion and plantarflexion. The ST joint predominantly comes into mainly into a transverse plane of movement and causes inversion, eversion, dorsiflexion, and plantarflexion. The inversion, eversion component of the ST joint has to be of predominant importance when we're looking at scans, because when we look at scans, it gives us exactly which area of the foot is he overloading, which area of the foot is he underloading. Basis that is when we decide whether the arch support comes in or doesn't come in. The metatarsal joint, again, largely in a transverse plane, causing again the inversion, eversion action and the flexion extension component over here. The next most relevant joint becomes the MTP joint. MTP joint predominantly comes in more on a sagittal plane. Very rarely we look at the transverse images, and this can deduct out how much amount of abduction and how much amount of adduction is he doing in. The reason why the MTP joint becomes very relevant is because that predominantly transverse bases your line of progression on the loading pattern of forerunners. The talocrural joint, which is in the tip of the medial malleolus, and we look at what is the angle at which it lands in through. The axis of rotation of the talocrural joint is approximately 13 to 18 degrees laterally from the frontal plane and at an angle of 8 to 10 degrees from the transverse plane. Again, basis how much the talocrural joint comes in with the angular changes on loading, it will determine how much and how is his toe off going to happen. So that determines his ground reaction time, the ground reaction forces which are embedded into it, and what is the transverse pressure of cushioning that is required out for a shoe support for these runners. Okay. The subtalar joint, again, the axis of rotation of it lies about 42 degrees superiorly to the sagittal plane and about 16 to 23 degrees medially to the transverse plane. The average range of motion for pronation is between 5 degrees and 20 degrees for 20 degrees for supination. Right now, though the pronation component is just 5 degrees, a lot of runners are misguided and misdiagnosed with an overpronation component which comes in here. Right now, why that happens, we see it up in the upcoming slides. Right. So now, when we look at a picture like this, you look at the first metatarsal. You go back to picture A, wherein you have the first metatarsal, the navicular, the talus, and the calcaneus. Right. The first metatarsal, the navicular, and the talus calcaneus determines what is the kind of the arch at which it's sitting in. Now, when we say an individual has a flat foot or a flat feet guy, this collapse on the arch needs to happen. When you look at the diagram on B, the first one on the top, you look at the base to the angulation there, it's about 52 degrees. Now, a drop of this 52 degrees predominantly determines whether the arch is collapsing in the runner or not collapsing in the runner. Anything increasing out here means that the athlete has a high arch. The shoe supports becomes very crucial when we look at these parameters mainly. When we look at the Lisfranc joint complex, the degree of sagittal motion for each TMT joint, the first TMT joint, the degree of motion is about 1.6 degrees. The second one is 0.6 degrees. The third one is 3.5 degrees. The fourth at about 9.6 degrees and the fifth at 10.2 degrees. This determines the collapse on the arch. Though the angulation, the degree of motion is very, very minimal, this on a larger picture determines how much the arch is collapsing. Right? Now, quickly move on to the next one, which is again a windlass mechanism of the foot, which we will see back onto the foot scans also. A windlass is typically a horizontal cylinder that rotates with a crank or a belt or a chain or rope to pull heavy objects. If you look back at the base of the metatarsal with the plantar fascia, that's where the windlass mechanism is very, very important. This function is important in providing a rigid lever for great propulsion during push-off phase. We need to determine how the extent of loading and offloading of the ground time is happening out in runners when we are determining the scan imaging. A sample scan imaging, this is predominantly when an athlete is being in stationary position. We use a CAD-CAM mechanism to identify the pressure source. So if you look at the image here, we break this down into hind foot, midfoot, and forefoot. The most important compensation that you see here is on the Lisfranc joint segments. So if you look at the dotted line, which is changing the midfoot from the forefoot, you'll actually see that there is a change in determining pressures, which is loading into the joint aspect here. When an athlete walks through basic scans, right? We will go back to a 3D scan to see how it goes quickly. Okay. So I'm sharing an athlete scan which is coming into originality. Is the window of the scan open and visible to everybody? Right. Now, when you go back to pressures and we start seeing pressures on forefoot. Now, this is a basic typical scan when we are looking at an athlete in a standing position. You look at the determining pressure in standing. I'm marking up a few pressure points over here, if you are able to see that. When we look at an athletic profile, it's very important for us to see which part of the hind foot, which part of the forefoot, and which part of the midfoot, the pressure difference is very, very high. This was an athlete who came down to us with an increased amount of loading pain, which was translating out onto the knee joint. If you look at his weight transferring ability, you will see that on the right hind foot, he's putting close to about 33 kilos of body weight compared to just 28 kilos of body weight coming in onto the left hind foot. You also go see the scan, you will notice that his midfoot transfer pressure in standing is completely missing. whereas the translation pressure on the mid foot of the right foot is just at about 78 grams per centimeter square. The percentage of weight distribution between the right foot and the left foot stands at 73% versus 66%. And the area of foot contact is at about 49 square centimeters versus 63 square centimeters. If you look at these factors, you can make out that he's actually landing more and putting more body weight onto the right leg compared to the left leg. The same athlete, when you go back to a walking scan analysis, you will notice that by the time he lands out his hind foot, the mid-foot contact pressures are also equally high, translating over one leg from the other leg. Right? Now, when you would look at a global picture of his walking, you will notice that his maximal pressure point on the left foot comes onto the third and the fourth ball of the metatarsal, whereas onto the right leg, the weight transfer is more onto the second metatarsal. When you go back to a 3D analysis to see how his weight transfers goes through, if I may just keep the cursor marking up onto his center of the heel of the left foot, you will see that the line of progression is predominantly going on the inner aspect of the big toe of the left foot. Whereas the moment you look at his right leg, you will notice that it is again going and translating slightly more outward. This gives off an angle of how much amount of toe out that he's landing at. The toe out angle is predominantly coming in because of the talocrural joint and the calcaneocrural joint. Right? These two determine as to how he is landing at the angle at which he is landing. So you can make out an angle of the pronation component on the ankle and on the subtalar joint component. When you go back onto seeing his lines of progression, you will notice that his lines of progression, his toe off just happens just above the ball of the second toe, whereas his entire toe off is happening out onto the right leg. Again, when we go back to seeing how much of pressure zones is he loading, you will notice that the red marker points are the high pressure zones, the green markers are the medium pressure zones, and the blue markers are the least pressure zones. You will see that a lot of his weight concentration is going out onto the forefoot of the right leg compared to the forefoot of the left leg. We move back to see how his running analysis comes on to. If you notice the picture clearly, you will see that there is zero toe off which is happening out on the left leg and an equivalent weight balance transfer which is happening up on the right midfoot. When we see this into a motion capture analysis, you will notice that even before his left midfoot has touched the ground, his forefoot has already started landing. So it's hind foot pressure loading. Now, if you look at the translation of weight transfers between his left leg and the right leg, you will notice that there is a good amount of transfer of weight pressure from the midfoot to the from the hind foot to the midfoot to the forefoot on the right leg. Whereas he straight away transfers out weight from the left hind foot to the forefoot, and then there is a reverse pressure that happens on the hind foot. Right? Now you will see that on the left side, you will see reversal of pressure which is happening. Right? Now this reversal of pressure predominantly determines whether the arch pressures are high, how much amount of weight transfer is he doing in, and what is the relevant risk of overusage of a muscle. Right. Now, when you go back to a global image to see what is the percentage of weight transfers that he's putting in, you'll actually notice that he's putting in anywhere close to about 94% to 92 to 97% of body weight pressures just on a very, very small area on the right leg. Right. Again, when we go back to translation images to see where is he loading high pressure, we will actually see that his weight transfers are pretty much imbalanced out between the right leg and left leg on a detailed analysis. Now, why is this very important when we're looking at the athlete translation? Is predominantly because it also gives us what is the angle at which he's loading and what kind of shoe fits him. How do we work on his strength and conditioning? How do we work on his rehab? Which muscle is he overloading? Which muscle is he underloading? Right? This predominantly gives you a total imaging of the lower body analysis just by looking at a couple of these scans. Moving down, when we go back to his postural scan, we may end up seeing that when he's in, again, when you compare it to the initial first photograph of a static scan, if I may just show you quickly. So if you just keep this in mind, you will see that 0 midfoot weight transfer, very high right heel weight transfer, and you go back immediately to see how his postural analysis looks. You will again see a similar picture over here. Now, we start doing motion capture analysis on the force plate and also using cameras out to see how his CAT cam and his landing happens. You will gradually see that the weight transfers are shifting between the right and the left heel, and there is a good amount of increase in weight transfer which is happening up on the right heel. Again, you can notice that except for his big toe, none of his other toes are in contact on the pressure plate when he is in standing position. The postural analysis gives us a very clear depiction of how much amount of stiffness, how much amount of tightness is induced in muscles below the pelvis and the hip. Right? Again, if I may just quickly show you another one. That is a comparison video of another athlete wherein we see that the arch of the midfoot has started to collapse. The arch on the midfoot has started to collapse, predominantly taking into consideration that the weight transfers are increasing out there. Right? Now, when you see here, you will again see that there has been a massive increase in pressure zones. You will see that the weight transfer on the right foot is at about 73 kilos of body weight versus just 52 kilos of body weight or weight transfer on the left foot, which is close to about 21 kilo increase in weight transfer from the person. Right? The collapse, again, none of the toes in contact, which translates out to a clearer picture of where the athlete wants the loading pattern. Basis this, a lot of these components can be rechanged, reshared back. Now, what do we see? Predominantly after seeing all of these factors, and I quickly take this out to the last screen share. Right. Now, what happens with it is we move on to the final stage of the thing. We go down to reporting of the scan. We go back to shoe recommendations. Sorry about the spelling. We start looking at the mechanical changes as what I introduced into the scans. start seeing where and what is he weight transferring, how does it move in, how do we start working up on strength and conditioning, how do we then work on his insole requirement, how do we then work up on the injury risk, because a scan predominantly gives us a clearer picture of where is he overloading, where is he underloading, what is the kind of injury that we're looking at, the overusage of the muscle on the whole. Okay. And that would be the end of my presentation. And thank you, Dr. Chirag. Thank you, Dr. Saurabh. Thank you for giving me this time and this opportunity to speak on this platform. Appreciate it. Thank you. Dr. Chirag? Yes, Dr. Vinay, thank you. Yeah, thank you, Dr. Chirag, for my time. And I'd be happy to take any questions. Yes. Okay. So the next speaker for this evening is going to be Dr. Alex Silva, the founder of Hands Pro Techniques. Dr. Alex. We welcome Dr. Alex Silva from Hands Pro. Dr.
Yes.
Alex, you can put on your video and take the presentation forward, please.
Yes. Okay.
Sure. Cheers.
Good evening. You tell me when I start, please.
You can go. You can initiate, Dr. Alex.
Okay. Thank you.
Thanks.
Good evening. It's a pleasure to be here. In this case, in this time, I am going to talk about Hands Pro instrumental manipulation in physiotherapy. The Hands Pro is a tool for the physiotherapist in the is a set of tools designed for manipulation of tissue, muscle, tendons, ligaments, fascia, and neural interface. This tool is created by Daniel Dulanto, is my partner, and me. There are three tools: is the tummy healer, the arm pro, and the leg pro. These three tools is to use for different parts of the body. For example, the tummy healer is used to go to see the video. Okay, in this case, it's used for the spine, lumbar spine, for different techniques in the lumbar spine. The second tool is used for upper extremities. In this case, I am work the deltoides muscle. And the third tool is the leg pro, is to use for slow extremities. In this case, is work the fascia, plantar fascia. Okay. But what is important? What is important? Use hands pro. Why? In the physiotherapy, there are 4 things important. The first is the percentage of the use of hands. The second is working with tissue. All the physiotherapists working tissue on the patients. Another thing is the number of patients in the different travels around the world. I need to opportunity with talk with another physiotherapist, and they told me the number of patients attending different countries is 20 and between 25 patients. And another thing is important is the heart muscle. If the heart muscle, if the physiotherapy work with patient with heart muscle, increase that joint pressure in your hands. Is more important because there are different research about this. Let's see. For example, in this research, say the first problem for the physiotherapy is a lumbar, but the second place to problem for the physiotherapy is the hands. In this research, what say this research? In this research say that problem in the physiotherapy is the damp. The damp is a more problem for the physiotherapy. Okay. In this research, say the manual techniques for more than 20 hours a week are 3.5 times more likely to have pain in the wrists and hands. This research say, and if the physiotherapy use your hands in the future, have a problem in your hands. For this reason, and this in another research, the use of repetitive techniques for years can produce degenerative osteoarthritis and change in the damp joints. Okay, all the physiotherapists use the hands for the different techniques in different countries. Okay, but if continue use for different techniques, the problem in the hands increase. For this reason, but what happened in the sports? Okay, for the reason in the sports, what happened? The physiotherapy attend a sportman. The sportman have a characteristics. First, harder muscle, more resistant, more hypertrophic muscle. But what happened with this? In the physiotherapy, more joints overload, more muscle overload, and increase joint pressure in your hands. Finally, pain. Okay, the pain is the problem because we every technique in the physiotherapy use the different fingers to give different or give different techniques to the patient. But what benefits have hands pro? Four benefits. The more important is this. For this reason, all the physiotherapy in America, in Asia, in Europe, in this time use hands pro. Why? First, the design of hands pro is anatomical. Shape of the hand is the only tool in the world if the anatomical design shape on the hands. Let's see. In this case, the design of the dump. You use the dump for different techniques. Fist, the physiotherapy use the fist for different techniques. Clamp, the physiotherapy use clamp for different technique. And ankles too. The physiotherapy use the ankle to use different in different techniques. Okay. This design help the physiotherapy to give different techniques for the patient. Another benefit, muscle work. With this tool, the physiotherapist use large muscle. Is very, very important because with another tools, the physiotherapy use the hands, but use the hands with another tools is a problem for the hands. Okay. Good. Let's see the video, for example. In this case, the physiotherapy is only the large muscle, not use the fingers, not use the dump. Okay. Another benefit about Hands Pro is the comfort. Why? For example, I have this it's not a tool, it's a boomerang, okay? But some tools is like this. It's think, okay? But what say the research about this is in the thickness of the tool is thinner. If the thickness of the tool is thinner, the heighter will be the load on the hand. This is a problem, okay? If you use a tool with this very thin, it's a problem for the hands. The physiotherapy have used a tools with different, okay? Another benefit is this. This tool, in this case, the Hands Pro, have 5 hooks. 1, 2, 3, 4, and 5. In this case, the tool is anatomical for the different parts of the body. And another thing is very important is the only tool that use the force when working with the patient, because use the physics for the different techniques in the patient. In this case, the great lever, less force, is used for Hands Pro to give different techniques in the patient. Finally, Hands Pro is not only the tools. Hands Pro use techniques too. For example, there are 3 techniques for different parts of the body: the passive instrumental manipulation, functional instrumental manipulation, and interface neural manipulation. go to see. In this case, for example, it's a technique to use biceps, muscle biceps, to use the tummy healer to work the fascial of the muscle biceps in this case. Okay, it's a patient with pain shoulder, not move the shoulder. Okay, this technique, the objective is related to improve circulation and decrease the pain. Another technique is the functional technique. Okay, in this case, go to see the video. This technique combines the myofascial and tension muscle with okay, it's a technique to use a not passive technique, is a move. The patient move the muscle, and after that, the physiotherapy use the technique to move more the tissue. The objective is make tissue more flexible, mobilization, improve mobility, increase run or motion, and decrease the pain. What's the conclusion if you use the hands pro? First, help the patients. All the techniques in the world only used to help the patient, but hands pro help the professional, because I showed the different benefits of hands pro, but another tools only help the patient. In this case, the design of the hands pro help the professional. Okay, is it comfortable for hands? I showed the research about the comfortable for the hands. Yeah, we use less stretch when you use hands pro, and it adapts to all the body. Finally, say the hands pro used in different continents. Okay, in America, Mexico, Europe, and Asia too. Okay, this time hands pro, the course of hands pro is in different continents. Yes. Thank you. If you have some question, please. Thank you very much.
Thank you so much, Alex, for your presentation. Wonderful presentation. And if any of our chairperson or speaker wants to ask any question regarding this, or any participant wants to ask any question, you can ask from Alex. And we will be organizing this hands pro course in India as well, in Delhi and other cities as well. We'll be organizing in Delhi and other cities of India as well, as soon as this COVID will be over. Dr. Vinay, if you want to say anything.
Nothing. I just want to add one thing. Very nice presentation. I hope deliberation delivered by Dr. Sita Raman and Alex Silva will help my colleague to enhance sport person performance. It is a pleasure having you here, sir. Thank you. Thank you very much.
Dr. Saurabh and Dr. Abhishek.
Good, Chirag. Thank you for invitation, and I hope to understand.
So when are you coming to India, Alex, or Christiana will
Yeah,
come?
the next year I am program my schedule to travel to India another time.
Yeah, for sure. You are more than welcome.
Yes. Okay, Chira, thank you for the invitation and see you another time.
Yeah, sure. Thank you. So our next speaker is Roy Araya from Argentina. So Roy is a FMS instructor, licensed kinesiotaping therapist, as well as exos educator. And Roy will be speaking on a topic, how to address performance prevention strategies in professional soccer teams. Roy is a PT, COMT, XPS, CSCS, FMS instructor, and exos consultator, and is from Argentina. Welcome, Roy.
Hi, how's it going, guys? Hope everybody's doing well back there in India. It's a pleasure to talk today with you guys, and thank you very much for the invitation. I'm pretty happy, really, to talk for the first time to India. So it's kind of pleasure and happy, like everybody have the chance to hear. Let me know when I can start and I shoot the presentation. Guys, I don't know how much time really I have, so let me know.
You have 30 minutes.
Perfect. So let's get to the point. Boom. So this is pretty much how you can develop performance prevention strategies in soccer teams. This is kind of a follow-up of experience that I already have working and consulting international with soccer players. I have the chance to work almost 2 years with a professional club in Brazil called Club Atlético Paranaense. They were champions 1 year and a half ago of one international cup. And I think they were like traveling around the world. So first, how to get from this structure to these structures. So pretty much it's an effort of the team. And how Henry Ford used to say, coming together is a beginning, staying together is a progress, and working together is a success. What is this quote means to you guys and means to everybody that is working in teams? Was pretty much, if you want to do everything by yourself, you're not going to make a long-term development and a long-term change. What you want to do is create a team settings environment and a team settings working together. So that is pretty much one of the first things that I have to do when I came to this team. It was like, how can I develop prevention if I'm not gonna educate them, if I'm not gonna teach all the system that I know? So one of the first layers that I have to build was pretty much what you understand about movement, how you gonna be implementing system strategies in this organization. So the first thing was just like, what I need to teach you. I need to teach you about movement health. First thing, basics. It's just like, if you are in pain, you are not allowed to play. And sometimes we know players are going to play with pain. So the first thing was educate the players and was educating the team and was educating the organizations. Like, if it's everybody are in the same page on the same table and we decide that a player can play with the consent of the player, knowing what could happen with that player, everything is fine, there's no problem. But the first thing, just like what I said before, just like we need to be on the same frequency, okay? It's like right now, we're in the same channel. I'm not allowed to speak in another room of Zoom. I'm talking to you guys. The second thing, if we understand that and we know how we're going to address that and how we're going to report that, it's just like what it means to be performance in motion, what it means to be movement performance, okay? And that is implied how you're going to move on the pitch and how you're going to construct all the movements that you want to create to reproduce that on the pitch, okay? That is how well you're going to develop yourself during the motions. Then is the part like everybody likes, mostly everybody likes, that is movement strength. How I can make you more strength and how I can create to you to produce more power on the gym. But then come the second problem. You can be really powerful on the gym. You can be really strong on the gym, but you cannot, or you don't have the capacity to produce that and reproduce that and take into the pitch. So now you're fast, you're strong, but actually you don't know how to use that in the pitch. So that's when overcomes how I teach you change of direction, how I teach you deceleration, how I teach you to actually do side steps, how I teach you drop steps, and how I teach you to reposition your body really fast so you can actually can apply everything that we are teaching you into actually real life. Because then what it comes is how well you move during the creation of your system's energetics. I mean, pretty much everybody knows we call develop of systems of energetics or energy system development, pretty much because that is where we're gonna do and work for all cardiovascular, aerobic, anaerobic, okay? All the systems, lactic, galactic, glycolytic, every systems that you have to perform. But that, and that is really important because sometimes it's the other time, it doesn't have to lose quality of the movement. Because otherwise, everything that your brains is learning is, okay, move in a bad quality of movement, but at the same time, yeah, gain a high intensity training networks in your body. And last one, and the most important for me, at least, since I have a background in health and science, is regeneration. And I want to say this quote that is for one of my friends in the United States, Jerry Lee. You cannot train and you cannot play well of what you cannot overcome of recovery. If you not recover and you're not regenerate properly and correctly, you're going to drag tissue, scar tissue, neural sensitizations. You're going to carry bad motion. You're going to carry DOMs. And you're not allowed, if you have the time and if you have the proper structures in your team to create that. And when I mean that, I mean regeneration and I mean recovery. Because at the other day, you have to train. We play a game last day. We have to do recovery today with my team. And we're going to start to train tomorrow because in 2 weeks we have another tournament. So, but by all means, if you're not recover, you're not going to start the week in the best proper way that your body can and your mind can. Okay, because when involved regeneration, there is something that we learn from you guys. There is meditation. Okay, there is how well you can move, and that is pretty much part of every discussions of movement basics that you think when you are in the team environment settings and you want to start thinking, how can I create prevention? Okay. So welcome to the movement process. This is what we use all the time. So we're going to grab a really big board and we're going to put there everything that we need to do during that week, during that day. Okay. So pretty much we have a schedule of everything that we need to address with all the players that we have, all the roosters. And pretty much we're going to start seeing after the assessment that we have with them, where are the weakest points, where are the weakest link, and what are pretty much everything that we need to work with them, since the joint, since the fascial tissue, since everything they have to do, like I said before, recovery, since everything, if they have, like, for example, lack of internal rotation and with a history of straining the adductors, everything that we're going to have, there are the markers that we are setting up, everything that we need to address. What are the best time during the training session? That's pretty much before the training or after the training on contra hours that we need to work with them, and how much time we're going to dedicate that, and how much stimulus we're going to have that during the week. And those are the phases that we like to teach. Okay, those are how we develop that prevention system strategies that we teach and we implement during these teams. So pretty much the first things that we want to implement is, everybody knows, functional movement screen. So the first thing is like how we open and we filter our rooster team. So pretty much for you guys to have an idea, in that team, we have 35 players. but in the whole spectrum of professionalism that we have during the team, we have 13 years, 14, 15, 16, until the 19 and 20. And then we have the other team, the professional team. So we have around 250 athletes. And the most important thing is how we separate those guys that actually are really in problems from the rest of the population of that team. And that is the first thing that you need to do when you have a lot of players or a lot of people. Let's picture that we are not in soccer, that we are in military in United States, and we have a platoon that we have a battalion, and they have 2,000. So the first thing is just like, if I want to measure everything in them, it's going to be endless. And one of the things that I can tell you that people get paid is pretty much to have sometimes big impacts. And how you're going to have that impact when you have that amount of player? Well, pretty much separates who is really, really bad and have problems and pain during motion from those that can move, from those that are okay. Then we can start filtering. I'm going to show you, just like in the other three things that we're going to talk, how we filter that when we get there. But pretty much FMS come to fill that space to separate, hey, you are not even able to do a single squat, okay? Body weight squat. You cannot decelerate. You cannot even stay in a split position and launch your body weight to yourself to the ground and go up. You're not allowed to even push yourself up from the ground. So if those markers, for example, that is one of the tests that we teach or that we implement when we're doing FMS to the players. If you don't have those markers, even your leg, your hip, your other leg is not allowed to stay in the ground when you are doing an active straight leg raise, while the other leg is supposed to get to 80. Well, you're going to have a big problem when you're standing up and you want to run and you need to flex your hips and your knee to accelerate and move forward with the ball, or trying to chase someone to create a mark. Those are the things that we address first. We keep all the time, or I teach to keep all the time in mind that everything that we are doing on the plane or on the floor or on the treatment table, or everything that we do with prevention or for prevention, has to have a mindset in relation with everything that the players are doing in the pitch. So that's why I'm telling you, when I think someone is not allowed to have internal external rotation on the tibia, I mean, you're gonna need that to decelerate and reaccelerate your body again. Okay, when you have to cut or when you have to chase someone and that is making a flick like Messi, you need those micro movements. That's why we're gonna address that. But before we address that micro movements, first we need to address the big ones. And one of the best way to capture those big ones is pretty much with functional movement screen. Then if I have those scores that are poor scores, or even worse, you have pain with movement, well, I'm going to use, or we teach those guys to use selective functional movement assessment. What I mean with this is just like, well, now I'm going to find the roots of your problems. Okay, I'm not going to stay with like, hey, this guy has a kneecap pain when he's doing body weight squats. This guy has knee pain when he's doing like inline lunge. This guy has a shoulder pain when we're doing like reciprocal mobility test. And this guy has pain when he's doing push-up. Well, now I'm going to break down every in the movement patterns that is going to lead me to see what is the root of the problem, the source of the problem. Because it's pretty easy to know that you have a problem shoulder when you tell me that you have pain in the shoulder. The only thing that I need to do is just like go address and tell you, oh, okay, this is the structure. This is the coracoid ligament. This is pretty much anterior capsular strain. This is pretty much a glenohumeral joint dysfunction. But I need to know if it is that glenohumeral joint dysfunction comes actually from the glenohumeral joints, come from the scapular, come from the mobility, stability of the T-spine, or comes from the other hip that is locked down. And since we're moving in slings and we're moving in couple rotation and anti-rotation, is that hip or actually is the knee or the ankle that is below the knee? And then with that information, I can address if I want the movement and correlate with what? With the strategies that we have. If you are manual therapy, if you like doing fascia, if you are more dry kneeling guy, if you are more mulligan guy, and then come the most important, you can be the best on those. But if you're not allowed to trigger with movement all the sequencing that these players or this player need, and then you are able to put on top of that capacity of the tissue, tolerance of the tissue, compliance of the tissue, dynamics of the motor control system to interpret that actually you are right now in a good position to move and apply forces, you're going to get back to the same. And that's when you enter into the return to play systems. That is pretty much what you do when you want to prevent, because everybody in this room knows this. The first thing that you're going to re-injure yourself is for a not good recovery and a not good testing during those stages of recovery. That's why the 4 that you have there is performance testing. I need to test where is your base, okay, of everything, or pretty much whatever I consider that I want to test. If I want to test power output, I can use contra movement sham in the force plate. I can use isometric in different ranges. I can use, for example, agility, 10, 20, 30 meters. I can use change of direction. I can use neurocognitive to see how you react in your visual, and pretty much everything that I need to test in movement. It could be FMS, SFMA. I can test dynamic, okay? So it's pretty much, I can test 1 time or 2 times, 3 times body weight, and I mean white balance test or hop test or broad shunt test that is related with my performance. But the performance testing that you have to have in mind when you're working on prevention, you have to imply what I'm gonna do with the movements, what I'm gonna do with the stability, what I'm gonna do with motor control, what I'm gonna do with the strength, what I'm gonna do with agilities, what I wanna do with movement skills, and what I'm gonna do with energy system development. When I have all those markers, I'm pretty sure that I test everything that I have in these players that he needs. And then it comes the last one. I need to regenerate that. And one thing that I didn't put there, but it's really important so far, I need to be able to monitoring that. So now I have the markers, but I need to know how those markers behave. And at this time of the century, I have the technologies that allows me to have like a living lab. If I have GPS, if I have heart rate, if I have something for the central nervous system or for the autonomic nervous system, if I have blood, if I have saliva, I can test pretty much everything. I can see those markers. I can see for everything that we have for system or apps that we have in our phone for the wellness and the TQR and the RPEs, how you're going to recover and how you suffer from that. So now I have those systems to implement prevention strategies, from the most simple things, that is how we join this movement, to the more complex thing that is just like how we prevent that. What about the team movements? How we develop that organization? Well, it's pretty much, this is how we teach. We teach like from the layer, the basic and most important layers, that is teaching how a body comports and behave from mobility and stability point of view. What are the efficient movement patterns that you should have? How is the performance supposed to be implemented in those places? And what are the skills that it needs in the sports? So that's where I was supposed to educate. What is movement really important? Well, it's pretty much is because of this. Everybody learns in sports. The first thing that they learn how to play the sports, playing the sports. No one, and at least I can tell for experience, in the countries that I've been, no one's teaching you how to run. No one's teaching how is the proper mechanics to run. No one's teaches like you need how many degrees of knee flexion, hip extension, hip flexion, hip internal, external rotation to be a good player. Actually, you playing since you are a boy with this model, technical and tactical. Then you acquire the physical training demands because you're playing. And no one's is teaching what are the core fundamentals. So pretty much for you guys to know, what are the core fundamentals that we need to build our house of performance and prevention needs to be built in core fundamentals. The core that we use is a mindset. It's just like, hey, you need to know that you need to have a good breakfast. Nutrition, you don't have a fuel, you can have the best manual therapy. You don't have the fuel for your body. Then when you have to put some low, need to build that. Movement is pretty much what everybody loves here in this room. And then recovery and regeneration. That is going to be the fundamentals to create what? The physical trainings and demands. That is here in the middle that you have, that is the prevention. When you have all that, guys, and you repeat it over and over and over, 5 minutes a day of strategies, 5 minutes a day, 5 minutes a day, start summing that into how much amount of time is during the week, during the month, and during the year. That is what we call prevention, actually. Is everything that we cannot repeat systemically for the assessment that we have, individualized for the players. When you individualize that for the players, that is easy. Because then you're gonna have the technical and tactical that, like I said all the time, you're not gonna forget how you ride a bike. You're not gonna forget how you kick a ball. But actually your body and your mind are gonna forget everything if you don't teach, because you didn't acquire that when you were young. And I like to say this all the time, great players I build from a solid foundation. This is the pillars that we use all the time for you guys to know. How is the assessment that we have? Mindset, nutrition, movement, regeneration. Here you're gonna see during the movement, this is where we focus here in this talk, is pretty much SFMA, FMS, upper and lower quarter functional examination and restoration, and how we teach movement skills, how we build movement skills, okay? How we build from how you're gonna have that alteration from mobility stability, because you don't have trunk tolerance. Let's say you have a weak core, that actually core we call upper core, middle and lower core. If you want to talk more deeply, we call pillars. So that's pretty much are the scapular and the shoulder girdle. The trunk, it will be the core that you know, and the other will be the pelvic girdle with the hips. So pretty much that is have to be really robust, strong, and at the same time mobile. So you can interpret when your body needs to be stiff, when your body needs to be relaxed, when your body needs to transfer energy from the ground up, or when you have to transfer energy from up to the ground and develop again to the ground, so you can propel yourself into the front. This is pretty much the job that I do all the time when I have to teach prevention, was pretty much what I said before. Teaching, educate the staff, because I cannot do everything by myself, and then teach to the players, be with the players, and then get together the staff from the clubs with the players. And then they can start seeing that, and I can oversee that, and I can see how they implement. And that's pretty much when we have success, because now the staff know it, the players know it, and they can work together. That is the magic. But is that, I can tell you, that is the more hard work that you have. When you can teach straightforward with someone, that's the easy part. When you have to teach autonomy to the players and autonomy to the staff, that is the hard part. And this is how we dance during the system. This is kind of the algorithm that we sometimes use. And it's pretty much this. Use the, like I tell you before, like I said before, you use the functional movement screens with the fitness coach and the physical therapist. If you have no pain, you're gonna go with the secondary screens. And the secondary screens, there is something that we used to do. There is, for example, it's just like, okay, now I need to know more about the ankle. in soccer. Now I need to know more about the knee. Now I need to know more about the hips. And now I need to know about the rotation of the trunk. And that's pretty much all the assessment that we have. And you can put that, if they are okay, in relation with mobility and stability with the performance testing. And now we can say, okay, now I want to see how strong you are when you are doing a squat, or now how strong you are when you're doing a jump. From the other side, then you can move yourself out and do all the field testing that we call, but this doesn't have to do with talk today. But if you are in pain, that it will be this part over here. Okay, now I want to do the clinical and orthopedic and neurological assessment, and I want to pair that with the movement assessment that we have with the clinical with SFMA. We're going down and we're going to have, okay, what are the functional testing like the physical therapy has to do? Perfect. There we have, for example, some kind of maneuvers that we can do from the physical therapists, like neurodynamics maneuvers or fascia maneuvers, and that is coupling with that. And at the end, from the medical side, you're going to have the medical perspective. If you have an MRI or if you have some kind of like image informations that we need, pretty much we use all the time MRIs and sonography or echography, and we have that data. And that's pretty much how we retest that. So how we loop again and retest that. We put that in electronic medical records, and then we have all the statistics with that. And this is pretty much how we do it. We have the FMS. The FMS, for everybody that don't know, there are 7 movements with 4 clearing tests. The clearing test is pretty much for the ankle, for the shoulder, for the spine, for extension and flexion. And what we're doing all the time, it's just like every month and a half or 2 months, we were assess the players from all the teams that we have, all the divisions. Then we have the top tier, pretty much that is from SFMA, that we call post-FMS. And then we have, sorry, and then we have the assessment of the breakouts from actually SFMA. With all this information, what we have is pretty much all the information that we need to build these reports. So pretty much all the reports that we have is basic on the deficit that we have. We put that information in a software called Move to Perform. So then we're going to have everything movement, all the movement patterns that we have with some compromises, all the movement patterns or all the structures and sources that we have with compromises, and everything that we test from FMS, SFMA, and white balance test, and hoop test, and broad champ test. We put everything there. So we inform the head coach, we inform the management, we inform the CEOs, and they have all the information for that. So that's pretty much where we use that. We have that information. And with that information, then we build this magic. We build everything related with all the self-myofascial release. Before that is everything that we can do on a treatment table, okay? But this is pretty much, that will be more like, if you are more in problem, I would say, if you are more in red flag, this is pretty much, it's like, hey, you move really bad. We need to have an intervention with you. We need to give you some exercises. So that population come with me and other physio and performance coaches. The big part of the team was split in 2 or 3, where they go all together. And these guys come and they have their own work. So they have like soft tissue, they have all the mobility. So here you can appreciate that we have everything for T-spine, everything for lateral fascial line and spiral line, everything that we have for hip flexors, everything that we have for hip extensors, okay? And everything that we have for the complex gastrosoleus. And at the end of that, we have everything that we use that is motor control. So now we have how you create a stiffness, how you dissociate yourself, how you decelerate yourself. You can see here how you move your leg until 90 degrees with control of the pelvis that you need all the time, how you create or dissociate yourself from the anti-rotation, and how you create hip hinge. So that's pretty much basic things that you're gonna need then to create power. Okay, this is pretty much, this is a nice sheet because this is pretty much, if you look up, you're gonna have group A and group B. Group A, what are you doing? Group B, what are you doing? So different types of breakdown of the big group of the soccer players, how you create that dissociation, how you put that into one group, and how you put that in the other group, and the things they have to do. What are the benefits of everything that we're doing so far? Well, it's pretty much, it's like you can move better, you don't have strain, you can recover better, and that is pretty much what is good for you. Okay. Why we use this? Well, I say before and I say now, you create a filter and you know what are the players that have to be in ICU or in critical conditions, what are the players that are in good condition, and what are the players that are in excellent conditions. And the most important thing about this, you need to assess and reassess all the time. Like I said all the time, this is a quote from Greg Cook, sorry. The first assessment is on the player. All the assessment that come after that is gonna be on you guys, because actually we are the professionals that are creating all the strategies. So first assessment on the player, all the assessment that comes after that is gonna be on us. And the good thing is just like we can make mistakes. I'm still making mistakes, but those mistakes are making me better professional. This is an example of the team correctives groups. So everybody's doing like the team corrective groups, like in this case, it's like active straight leg raise with core engage. So with those bands that you're seeing, we are creating like a reflex on the core, because you have to pull yourself down. So you create torque on your body. The other legs is keeping straight, and the other just like with the straight leg is going up. This is actually doing after that you're doing soft tissue, okay? Then we're going to start working some things in movement skills. So this is pretty much is teaching the first team. We have really players, good players, that they know how to play soccer, but they don't know how to move. And that is the big risk, because you're using all the time, and that's create what you guys know. This is repetitive injury. Okay, or we create injury by repetitive stress. So we stress in the joints and the tissue all the time in the same way, in the same manner, because it's the only pattern that you know. And now we need to teach you better. Here's one coach that we coach. That is a really good coach. He was teaching to the players how to activate in a proper way with split position. This is pretty much, remember that I talked to you guys about return to play. So this is pretty much all the phases that we cover and have to cover from the different point of view, okay, in the prevention of recurrency of the re-injury. That's what I told you before, that the return to play is really big topic into the injury prevention. This is one session of regeneration that it have to be ludic. So they have in a really warm play. They're using the legs just to move slow. They're using something that in soccer they don't use all the time. There is the upper body, and they're playing. So it's a team setting. And at the same time, they're moving just a little bit. This is one of the things that we do in regeneration on the pitch. This is when we're doing regeneration on the trips. And this is pretty much something for you to go before we finish. There is the amount of corrective sessions. Remember that I told you how we implement that strategy. So that is the amount of that we do every month. How many sessions we have, how was the impact of those sessions, okay? And there was just like 2016, 2017. And this is pretty much, again, the total amount of sessions that we have during that year. How we did that, okay? We have a comparison of the muscle injuries. Structure is pretty much DOMS or muscle ache. Functional, that was what I mean. Structural is pretty much when you have a grade 1, grade 2, or grade 3 of that. We see how drastically was the impact in 2016, but the main thing is was in 2017, we have international competitions again. So we have much more games than in 2016 and 15. This is pretty much how we categorize these injuries, okay, into the Munich Convention. So 1A, 1B, 2A, 2B is functional, 3A, 3B, 4A, and then we have concussions. So that's how we classify that, and how what we saw, it's just like, okay, we start having some kind of decrease of injuries. We even have the structural ones, but it was decreasing even though. This is a case study that I'm going to pass fast because I'm on time. So there was just like a left adductor strain. The score of MS was a 9 of 21. He was with pain. This was all the lower quarter functional examination that we have from that player. So we have knee hyperextension, TV external rotation, decrease on right leg stability, increase in weight to the right. So he was shifting that way, decreases hamstring mobility, both decrease on right hip flexibility, flexion mobility. And this is what the assessment of phase 1, phase 2, phase 3A, phase 3B, 4A, 4B, and 5. Okay, so in different phases, we are going to assess different types of things. Sometimes like maximal aerobic speed, we're gonna try to address that at the beginning, and then we're gonna address that when they are running. All the mobility that we started doing and how that complexity in the mobility was addressed. In the phase 1 is really easy. In the phase 5, we have everything that is more like in flow. All the stability that we have, and that involves pretty much working on the pool, outside the pool, working in isometrics, doing wall drills, working with, with minibands, working, for example, everything they have to do with the pillar work. Then all the correctives that we do on top of everything that we do for the injury. All the movements that we start to prepare. So it's pretty much like reorganizing the motor patterns from walking to the weight shifting, to the single leg balance, and how we are gonna involve that until we're gonna do sprinting. So we're gonna do in marching, we're gonna do in backward lunge, we're gonna do in forward lunge, we're gonna do in side step, we're gonna do in everything that we build. So at the end of the stage 5, that player can actually be running. All the strength training that we're doing on the gym, from upper body, lower body, and core, and everything that we have to do to work in energy system development. So that's pretty much something that we are building from the perspective that when we have someone that has an injury, this is how we work. This is how you can see when we put correctives, how we start even working in injury prevention during the rehab. Well, I hope I finished on time. Sorry, I passed 2 minutes. And I want to thank you again for the invitation. Here's everything how you can reach me and you can connect with me. And I hope, looking forward. Thank you, guys.
Thank you so much, Roy, for your wonderful presentation, and I hope it will be helpful for all the therapists who were seeing this, and even for me as well, as I am into sports training. so it will be beneficial for me as well. And,
Glad to hear that. Glad to hear that we can help.
Yeah.
That we can help in this community of people that we love sports and we are monotherapists and we like this thing about try to diminish the injury of our players so they can be better. If you have any questions or you want to ask me something, I'm more than open to that. Of course, if we have time, otherwise you can reach me, like I said before, Facebook, Twitter, Instagram, my mail, the web. There's no problem with that.
Yeah, Dr. Vinay, if you want to ask any question.
No question, sir. It's a very good presentation. Thank you, Rodrigo.
Thank you, Bene. Thank you for the invitation, doctor.
Anji, it is a pleasure of have you as our guest speaker. Thank you. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Vinay. Dr. Abhishek, if you want to ask any question. Roy, thank you so much for your wonderful presentation.
My
and
God,
we are
thank you.
glad that you have presented for the Indian therapists for the first time as well.
Yeah.
Yeah, and we had organized this summit with the help of Osteopro and Osteopathy Association of Italy, as well as the European Register of Therapists as an academic partner with us in this summit, and also the Assam Downtown University as an academic partner of this summit. So we would wholeheartedly like to thank all the associations, those who have been the academic partner in this second International Web Physio Summit organized by Academy of Exercise Health and Therapy. And this 2 days summit comes to an end with the end of this sports colloquium. Yesterday we had 3 colloquiums, neuro, gynae and ortho. Today we had cardio in the morning and pediatric in the afternoon, as well as the sports in the evening, and that comes to an end. So I would like to thank wholeheartedly to all the chairpersons, co-chairpersons of Summit of Colloquium, as well as the organizing secretary, Dr. Abhijit Datta, co-organizing secretary, joint secretary, Dr. Abhishek, treasurer, Dr. Saurabh Kumar, our patron, Chief Patron, Dr. Krishna Garg, our patron, Dr. NC Talukdar, who is the Vice Chancellor of Assam Downtown University, as well as co-patron, Dean of Studies, Dr. Bandana Datta, and our co-patron, Christiana Villela from Italy as well. And all the participants who have attended and who had trusted on us, and also thanks to our organizing team who seamlessly worked for this summit, worked so hard for this summit, especially Dr. Abhishek, Dr. Saurabh, Dr. Abhijit, and our summit coordinators, Dr. Suresh, our joint secretary, Dr. Avinash, Dr. Farzana, Dr. Amar Mishra, and all those, because so many of people have done their hard work to make this successful. So I would like to request Dr. Saurabh to say a few words.
Thank you so much, Dr. Chirag. It's indeed an honor to be part of this team who has organized this grand event, second International Web Physio Summit. It will be a small thing to say that every dignitaries, every speaker, they have contributed more than what we did. I think they have spared their valuable time for us, and we are really grateful to them. Those who are supporting us in any way, they are literally our pillars of strength. Each attendee, each speaker, our chairpersons, co-chairpersons, everyone is supporting us in a way or other, and we are always grateful, and we will be grateful in future. We will be surely hosting further more and more web summits like this. Each year we held it, and this year again we are able to hold it because all of you supported us. Thank you so much. Thank you so much for being there for us from Academy of Exercise, Health and Therapy. We are all grateful to you. Thank you again.
Roy, you can stop sharing your screen.
Okay. Perfect. Done.
Yeah, you want to say anything?
I just want to thank again, and I think you are doing a great job, guys. Keep doing that. Keep promoting the word about manual therapy, orthopedics, osteopathics, chiropractics, everything that you want to do to improve the quality of life of our world, our people. You guys back in India, I'm around the world, and the players, and that I think that is what we're doing all the things about education. We want to improve our quality of self, networking around the world to see what can we steal to other guys in a good sense, how we can learn from each other, how we build that community, how we make grow physical therapy, manual therapy, orthopedics, everything that we can do for these people around the world get better health. That's what I appreciate about you guys. Thank you very much for the invitation again.
Thank you, Roy, for your wonderful words as well. And last but not the least, Dr. Abhishek.
Thank you so much, Dr. Chirag. Thank you for the time and the dedication for this event. I hope we can work together in near future also. Thank you, Dr. Arya. And I would like to again, thanks to your every teammate, our every chairperson, co-chairperson, and every team member who work a lot for the success of this conference. I can say next year will be biggest, or if the pandemic will over, we will conduct a offline session. Thank you so much. Thank you, Dr. Chirag.
Thank you, Dr. Abhishek. And thanks to all, this summit comes to an end. All the participants will get their certificates in 2 days, as well as all the chairperson, co-chairperson, and speakers will also get their certificates by Wednesday on their email as well. And I would like to thank everybody, my teammate, my strength pillars who have been keep supporting. Most of them are behind the you can say curtains, and behind this summit, those who are keeping me supportive, they are giving me strength to do my best and to give my best, to deliver my best to all the therapists throughout the India and throughout the world. And we have tried our best to give the best, and we will try our best to keep raising the standard of physiotherapy in India as well as in the world. Thank you all participants. Thank you all speakers. Thank you all chairperson, co-chairperson, and my team. If anybody wants to ask anything, or if anybody wants to say anything, they can write down a contact number. They can WhatsApp me, or either they can my contact number is in flyers. So if anybody wants to ask anything, they can contact over there. And keep joined with our Facebook page and Instagram page, Academy of Exercise, Health and Therapy, for the near future events and everything. Thank you so much, guys. Thank you.